Karma, we good? Okay, all right, well, good morning, everybody. It's one of the few mornings I was hoping for bad weather, so people would show up. So thank you so much for being here on an amazing day. I promise it'll be nice weather when we're done. So we'll have plenty of time, but I really appreciate you showing up. And oh my gosh, my mentors just showed up. Now I'm gonna be nervous up here. Dr. Hannafin and Susan Tofty. So, all right, so why are we here? You know, we're here to learn, we're here to share. We're gonna be talking about the relationship between food allergy and eczema. My name is Eric Simpson. I'm a dermatologist here at OHSU, very interested in eczema research, eczema treatment, eczema prevention, most importantly. So I've been interested in eczema for over 20 years now, thanks to Dr. Hannafin, who's sitting down here in the front row, as well as Susan Tofty, who's a physician or a doctor of nursing and has done lots of research. So they kind of taught me how to do research, how to see patients, how to take care of patients. But I think it's pretty easy of like why we do this, you know, and why are we all here? It's because we understand this burden of eczema, of allergies on kids, on adults, on families. So that's why we're here, because we have some kind of ownership, some type of relative, some type of child in our family who has and suffering with this condition. And we just know it can be a difficult burden for patients in terms of like the skin lesions and the constant scratching and itching and oozing and trying to understand why is this happening to me, the loss of sleep in the kids, the loss of sleep in the parents and the family. And then, you know, patients with skin of color have even additional burdens, right? So they have can leave back dark spots, leave back white spots, and then thinking about locations of on the hands, on the face, you're embarrassed going to school, you get bullied, and the stigma, and then just the misinformation or, you know, the why. I think the why is always an issue for any chronic condition, meaning conditions that continue. There's always a lot of theories of why this is happening. Why did I get this? Patients have an amazing amount of guilt. So parents, patients feel like, you know, people say, just stop scratching. It makes you think that I've just done this to myself. And then all types of well-meaning information and recommendations from friends and family. So what do we know? I'm going to be turning this over to more experts here shortly, but I'll just kind of set the stage of kind of where we are from a scientific field. We know that these two things exist in every patient of any age with atopic dermatitis. You have this kind of dry, leaky, dysfunctional skin barrier, so like the top part of your skin. And then with that, you also have this hyperactivity. That's the inflammation. That's like the redness, the swelling, the bumpiness, the oozing. That's the inflammation part. And then you have this dry skin part. And there's debates in the science field of like what, you know, which one's more important and what chicken or egg, where does it start? And we know there's really strong genetic predisposition to both of those things. You can find genetic mutations that make you a little bit more at risk for atopic dermatitis, both in the barrier, in the skin, and in the immune system, the inflammation. And then there's a lot of other factors, a lot of other research, really interesting research that kind of changes whether you're at risk of getting the condition. So did you grow up on a farm when you were younger? Were you exposed to a cat or a dog? And then air pollution, we're starting to see can be a factor in whether you get eczema or not, and then the severity of the eczema. So there's a lot of research, including a real recent paper just a couple days ago, that the risk of eczema in a population is related to pollution levels. Now, I always say the effect that these have on your eczema and the eczema risk is minor. You know, they're all small, little additive risks. And so I can't say, you know, please move to Hawaii or please move somewhere else and that your eczema is all going to go away. Sometimes people have that experience, but it's very rare. And so what we're starting to understand and why we call this like partners in crime is because that inflammation, that immune abnormality, it's actually like a hyperactivity of the immune system. So you can't kind of fix it or strengthen it. But we're understanding that immune system, that inflammation, maybe is driving all of these things. Okay, so a lot of the research back 20 years ago or so used to feel like, okay, food is the bad guy. That's the criminal. That's kind of causing the eczema and driving the eczema. And then we started thinking, and more recently, oh, maybe it's the eczema that's causing the food allergy. We'll be talking more about this. And maybe that's the relationship between those two conditions. But now we're starting to realize, like, okay, maybe these are partners. And maybe actually the problem is, at least part of the problem of this combination of why we see these conditions, it's one thing. And we know this because there are some advanced treatments for more severe eczema. You can treat one chemical in the middle to treat all of those things. Now, I'm not saying that to go on the treatment or that's what you need. I'm just saying that it's a nice example to show that we're starting to figure this out. We're starting to figure out the inflammation. There are some recent guidelines from the allergy community, from the scientific community. I really liked these guidelines because they had patients, had nurses, had primary care who would voice their opinion about the data. And just as an example, we'll go over this, but this was a recommendation, and we'll go through why they made this recommendation in terms of just dietary restrictions. So just in general, with patients and everyone involved, they did not recommend that dietary elimination diets would be appropriate for atopic dermatitis, and we'll go over the reasons why. Okay, so hopefully today we're going to answer some questions. So things like, what's the burden of pediatric atopic dermatitis? That means, like, how bad is it on the child? How bad is it on the family? And then how are these two conditions, eczema and food allergy, related? And when you hear the word eczema, we're going to be using that as the same word for atopic dermatitis or atopic eczema, just because eczema is usually kind of a broad category, but we'll be using those words interchangeably. Can we treat food allergy? So we have all of our allergy and pediatric dermatology colleagues here today, which I'll introduce here in a second. And then can we prevent it? That's the holy grail. Hopefully we can prevent food allergy. Hopefully we can prevent eczema, and we're all involved in research with that in mind. And then what kind of resources do we have? So hopefully this is going to be one resource for you. So this is the Clear Eczema Center. The C is clinical care, L, lifestyle, E, education, A, advocacy, R, research. And I feel like this is, part of that education silo, basically. And thank you all for online and here in person for submitting questions. This is the beginning of the Eczema Center. So you're all, like, your input is going to be really important for creating this center. And so I already see that there's a need for more education for all of us. All those questions were amazing. Some related to food allergies, some not. And so we were thinking, and we can brainstorm at the end, of having some Q&A sessions regularly throughout the year online, just to answer some of these really difficult topics, because this is a very, very complicated condition. And so I really appreciate the enthusiasm from online and all those questions when you signed up. So this center basically was born out of my two mentors, Francis Storrs and John Hannafin. They were both and are still eczema experts who treated patients their entire career and taught me everything I know and inspired this center. Dr. Hannafin started the National Eczema Association, and I don't want the Clear Center it's not replacing the National Eczema Association. It's kind of an association, an organization for our local folks, basically, in Oregon and close by. So what isn't the Eczema Center? Well, it's providing kind of more specialized care. We have a multidisciplinary clinic, meaning we have an allergist and a dermatologist seeing patients both in the pediatric and adults. We're going to be increasing our educational efforts. We're going to be integrating and providing opportunities both for research and for survey research and for understanding the burden of the condition on our local population. We're striving to kind of build community. I really feel like building community can be therapeutic, meaning can help them on the medical side. Hope it's collaborative. And then we're still going to be working really strongly with our advocacy partnerships. We're all members of the National Eczema Association. So there's a lot of people. And they're all passionate. These are medical assistants, nurses, physicians, nurse practitioners, physician assistants who all treat patients with eczema and are interested in going beyond just your routine clinical care. So I encourage you, if you haven't already, to sign up for the Eczema Network, community network, just so I promise we won't spam you with lots of emails. It'll be, we're going to be starting with a first newsletter, just to kind of let you know what are some important national advances in the field, and then also local opportunities and local advances in the field. So, and these will be out. Karma will have these available so you can sign up. Okay, so fortunately, I'm going to stop talking soon because we need to get the experts out here about allergy. And so we're going to be hearing first from Julie Dosha, who is on the ground level. She's a pediatric dermatologist. She's the program director for our residents at the department. So she'll be talking about the patient experience from her perspective as a clinician, and then some tips. Then we'll be talking from Jessica McDougall. So she is an allergist that we recruited here to OHSU to perform food allergy. She's a food allergy expert. She'll be talking about the new Food Allergy Center. Then we'll be hearing from Karen Anstey, who will be giving us more information. She's an allergist here at OHSU, who will give us more information about this connection between the two, kind of help us think it through. And then we're really fortunate to have a patient here, a family here who has a child with food allergies, and we'll be having a discussion about that experience. So thank you so much for being here. That will be led by Sham Joshi, who is the head of allergy here at OHSU, who's just done a tremendous job in building the program over the last 5 years or so. Then we will feed you and have some videos at the same time, and we have some low allergen food coming from Pollo Norte. And then we'll be hearing about treatment of food allergies. So what are some options? Where's the research going? We'd like to prevent it, but once you develop food allergy, what can we do to treat it or even make it go away potentially? Okay, so it's my pleasure to introduce Julie Dosha, Dr. Julie Dosha, to talk about the pediatric burden of atopic dermatitis.
Thank you so much, and good morning to everyone. I am delighted to be here and honored to be here to speak to you today about a very common thing that I see in my clinic. I, of course, have a lot of patients with eczema. I see only pediatrics, so that is ages 0 to 18. These are some of the faces that I would see in my clinic on a daily basis. And so I'll be going through some of the most common questions that I get in my clinic to me. So number one, what is eczema and how do you diagnose it? So I like to start, eczema comes from the Greek word meaning to boil and to break out, which as we all know, eczema can cause a lot of those symptoms of itch. And we really, like Dr. Simpson mentioned, use it as an umbrella term for the condition that causes itchy, red, inflamed skin. And I use it mostly interchangeably with atopic dermatitis. So we'll be speaking kind of interchangeably today. A typical story, so it's a long-term chronic inflammatory skin condition. We see phases of more severe flares, less severe times. It often runs in families, may occur alongside other, quote, atopic conditions like hay fever, seasonal allergies, and asthma. And I would say usually the appearance and the history is sufficient to make a diagnosis. And I'll kind of go more into detail about what that appearance is, especially in children. In some cases, we might consider a skin biopsy, but especially in kids, that's rarely needed. So eczema is quite common in childhood. We estimate 20 to 25% of kids will have eczema. It often appears in those first 6 months, can take several years. And interestingly, it may look and act differently as the child gets older. The location and appearance might change. And then some kids do seem to grow out of it, or at least the eczema gets more mild over time, but it is very hard to predict who that will be. So I don't really have enough evidence at any visit to say, like, yes, this is someone who will grow out of it or not. So in infants, we mainly see eczema kind of start up on the cheeks, the chin, and the scalp. Very classically, it spares the diaper area, so that is not an area that is usually involved. And interestingly, you can kind of see on this picture, the nose is usually spared as well. Those are kind of classic features that I think of for the infant, and the skin might look more red and weepy. Once we get into kind of that older baby stage, the elbows and knees start being common, especially as they start crawling. The cheeks are still a very common area. In toddlers, we start to see it more in the creases, so the creases of the elbows and knees, around the wrists and ankles. The eczema might kind of look more dry and scaly. The skin can become thicker from having the eczema for a long time. And then older kids, again, those folds of the elbows and knees behind the ears and the hands and feet tend to be more common. So that is kind of in a nutshell, how eczema presents to my clinic and how my pediatric patients look. So the second most common question is a food allergy causing the eczema? And I know Dr. Simpson kind of introduced, this idea that there are a lot of players in what happens with eczema. It seems to be a very complex disease. And, we used to think like, food allergy is that criminal that is causing eczema. And if we just identify it, it will go away. But really, there are so many interplays of genetics, environmental factors, that immune system activation, and we're recognizing some imbalance of the microbiome as well. So those are the bacteria that live on our skin and our gut. And all those factors are kind of playing in. So there isn't really like one factor, one root cause that we can identify for each person over and over. And so eczema and food allergies can, and they do often occur in the same people, but food allergy is not that root cause of the eczema. Now, I want to talk a little bit about that skin barrier problem. So we mentioned dry skin. In a healthy skin barrier, we really see those skin cells sticking together the way that they're supposed to, where they keep in moisture, they act as a barrier to keep things on the outside out. In eczema, what we're really seeing is that skin barrier is weakened. So moisture can escape much more easily from the skin, and then things from the outside can really penetrate, irritate the skin more easily, inflame the skin more easily. And this is a diagram kind of showing what I'm talking about. And so this is my own creation, but kind of how complex, like how I think about it. So we have that skin barrier dysfunction, really, having that interplay with the immune system, and then some other factors that go into that. There's some evidence, yes, that eczema can actually cause food allergy. So when the skin is impaired, those allergens can get in through the skin and have the immune system get primed to that allergen specifically, causing what we call a type 1 food allergy. And so I'll let the allergists talk more about this as the experts, but guidelines now recommend earlier exposure through oral means to foods that are high risk, such as peanut and egg, to try to prevent that kind of food allergy in our higher risk patients. So the third question, how do you treat eczema? Unfortunately, we don't have a cure. yet, but our goal is really to improve symptoms and achieve long-term control of the eczema. And we recognize, this affects more than the skin. A lot of the families I see, they come to me with, the child has some behavior issues, sleep issues, not just for the child, but for the whole family. It can lead to self-esteem issues as a very visible disease. Eczema has been linked to higher rates of anxiety and depression. We really can see a lower quality of life for the patient and the parents and families. It can affect relationships. It can affect work, finances. So it is kind of an all-encompassing disease. And so that burden can be very significant. So kind of recognizing that and treating as best we can to help all of those things. The pillars of treatment, so avoiding triggers, I'll talk a little bit more about that. Having a routine skincare habit focused on improving the skin barrier. So emollients, those are moisturizers, even when the skin is clear, to really repair that skin barrier, and especially doing that after bathing, kind of sealing in the moisture that was gotten after a bath or a shower. Moisturizer should be bland, fragrance-free, and thick. And then I always harp on the fact of avoiding soap. A lot of baby soaps actually contain fragrance, and soaps in general just strip away the natural oils that are on our skin. So they always work against us as far as moisturizing. And then medical treatments. So triggers for eczema, every child is different. Recognizing triggers, avoiding them is an important part of managing eczema. I've listed some of the triggers, but I recognize that there are more that I didn't list. Dry skin, heat and sweating. I've had, patients say like, oh, I feel like I'm allergic to my own sweat just because of how irritating that can be. Various irritants, whether it's fragrance, soap, infections. So having skin infections is fairly frequent in some of my patients, whether it's bacterial or viral infections. Environmental allergens can be triggers. And then I did say food allergy is not the root cause, but if you have a food allergy, that can be a trigger for your eczema. So working with your allergist on that. Prescribed treatments, I won't spend long on this, but we have various ways to treat inflammation, whether it's topical treatments, corticosteroids, non-steroidals. There's something called phototherapy, which is a UV light that's shined on the skin to help with inflammation. Various oral medications that can sort of treat that inflammation from the inside out, and injected medications. And that these treatments really depend on the severity, location, and the age of the person. So it should be an individualized treatment plan, and talking to your doctor is really the best way to get to what treatment is best for you. So the last question, babies, I told you have a good amount of cheek eczema or cheek involvement. When you're introducing foods, having those rashes on the face, what do I do? It can be a very confusing picture. So if there are no other symptoms, it's the rash on the cheeks that develops, no other symptoms such as lip swelling, tongue swelling, hives, or vomiting, then it's likely to be what we call an irritant dermatitis from having those foods contact the skin. And I do recognize eczema can make starting solids pretty challenging and uncomfortable. So my tips are applying a barrier ointment. So that means Vaseline or Aquaphor before and after meals. So that will act as a barrier between the acids and juices of the food, and prevent the contact with the sensitive skin. Avoid wiping the baby's face like multiple times during the meal. So really trying to save it for the end, wiping with just lukewarm water. Teach using utensils sooner rather than later. That can be a challenge, but a good goal to have. watching out for acidic or juicy foods. Those tend to be the most irritating. And then if it has become a negative experience, seeking some feeding support could be helpful. And then a note, eczema can appear redder and more inflamed if the baby's overheating, if they're crying or rubbing against something. And so I would counsel to not jump to blame the diet or that specific food or eliminate that food right away without speaking to your doctor. And then I know Dr. Simpson mentioned this, but that I've kind of shown like that burden can be pretty significant. We're really hoping to build community. I think it is helpful to know that other people are going through the same thing and that you're not alone. And so this is on our website as far as community resources as well. Thank you.
Okay, we have time for just a couple questions for Julie. We'll have a Q&A session at the end as well. So, but anything that you want to clarify, feel free to ask now, or we can move on to our next speaker. And then you're looking online too? Okay. I had a question, but I forgot it. Oh, it'll come back to me in the Q&A session.
You taught me most things I know, so I don't know what your question is.
I guess we'll go to the next speaker then. Okay, thank you. Okay, so I like that you plugged the website. Thank you for that, Julie. So there's a lot of resources. Like I'm not even aware of all the resources online. So check it out. There are links to videos. There are we made these animated videos to try to help understand eczema. You can tell that it's kind of our first attempt at using animation, but hopefully it's nice and clear information, short. Let's see what else is on the website. Oh, there's even like mental health resources. We're not going to be talking about mental health, but you can imagine that that's an issue with every chronic disease. There's links, as Julie said, Camp Blue Spruce for food allergy, National Eczema Association, and some other associations that can provide support. And I misspoke. I said Dr. Hannafin started the National Eczema Association, but I think even back then, I don't know how many years has it been, 30 years? 40 years? Yeah. Even back then, Dr. Hannafin had the understanding or the collaboration with patients. So a patient started the NEA. Susan Tofty, nurse and research nurse, started the NEA. So as a collaboration, and a few others were right at the beginning. And that was started right here in Portland. They've now moved into California, but it's kind of a...
National Eczema has a patient expo, which
Oh,
is
yeah.
June. It will be in Denver, Colorado this year.
Okay, thank you.
I think it's in June, so, but if you go to the website, it has a big...
Yeah, it's a big version of
Yeah.
this. 2
Yeah.
days, they have places for kids and
programs for people that need it.
who's financially can't make it there. So Denver, June.
I think it's in June. I'll have to double check.
Great,
but-
thank you. They've been volunteering there since the very beginning. Okay, so real pleasure to now introduce Jessica McDougall. She's an allergist who will be talking about the Food Allergy Center that's just getting started, kind of what the availability is and what that's going to provide. OHSU is really excited about this center. Thank you.
Thanks, Dr. Simpson. It's great to be with you guys today. Thanks again for coming inside out of the really sunny weather. Again, I'm Jessica McDougall. I'm one of the newer faculty members at OHSU Allergies. So I just started this past September, and I have the pleasure of introducing the Burghardt Food Allergy Center. So it's the first dedicated food allergy center in the Pacific Northwest that was made possible by a generous gift from Dale and Julie Burghardt. So the mission is, of course, we want to provide transformative medical care and we want to conduct state-of-the-art research for food allergy. But similar to the Clear Eczema Center, we really want to place an emphasis on education for our patients, for the community, and for other providers who are taking care of our patients. There's a huge psychosocial burden that goes along with having food allergies. And if we can help people live more healthy and rewarding lives with their food allergies, that would make me super excited. So who are our food allergy center providers? Kind of meeting the team. There's me, I'm the director of the Burkhart Food Allergy Center, but I could not do it alone. I have wonderful other providers that help me out. Dr. Joshi and Dr. Anstey, you're actually going to hear from today. And then we also have Dr. Yates and Dr. Sabella. Nothing is possible without our clinical staff. So our nurses are absolutely wonderful and provide excellent patient care. So we have our nurse coordinator, Christy, and then we also have our nurses, Michelle, Mary, Renee, and Marie, who I trust with my patients. And then what will you find here? So the goal is to do a multidisciplinary approach to complex food allergy, expertise in diagnosis and management of food allergies, both IgE mediated and non-IgE mediated, providing treatments that aren't widely available, such as immunotherapy, which I'll be talking about later, and then access to our other specialists. So working closely with our dermatology colleagues in our multidisciplinary eczema clinic, and then also working with our gastroenterologist, the digestive team experts for things like the eosinophilic esophagitis program, which will be coming soon, hopefully with Dr. Anstey over there. And that is just a quick little bit. Any questions before Dr. Simpson introduces the next speaker? Yes.
IgE mediated, what is that?
Yes. So IgE mediated, IgE is an antibody that can circulate in your blood. That's for allergies. And so when people have IgE mediated food allergy, it means that they have higher levels of that antibody so that when they see the food, it makes their allergy cell kind of go like this and degranulate, causing histamine, all these yucky chemicals that will cause hives, swelling, vomiting, difficulty breathing, as opposed to something that's non-IgE, so they don't have those antibodies circulating and it's through a different mechanism. But that's a great question.
Do people need a referral to see allergy specialists at the Burkhart Center?
Yes, they do need a referral from their primary care doctor. Great question.
And have you already started seeing patients?
Yes, so we've already started seeing patients. I'll talk about it at the end of my other presentation, but we've also started our oral immunotherapy program. So that started at February 1st. So that's now available for patients. If people have interest in the immunotherapy programs, they'll get a referral from their primary care doctor into our allergy program and then decide with their allergist whether or not they should come for immunotherapy with me. Great question, Dr. Simpson.
If we're already set up with the allergy at OHSU,
Yeah.
is this a separate thing to be with them?
So you're already set up with me, so you and I can talk about
Okay.
immunotherapy. But for other people who are seeing, for example, if they saw Dr. Joshi or Dr. Anstey and they had interest in oral immunotherapy for treatment of their food allergy, they would then refer to me and I would deal with only the immunotherapy portion of their care and they would still see their primary allergist for everything else.
Is IgE testing covered by insurance?
Yes, it should be covered by most insurances. For food allergy, it's different, a little bit different with environmental allergy, but for food allergy, absolutely, it should be covered. Those are all great questions. Any more, Karma? Okay, perfect. Well, I'll be back up here at the end, so keep the questions coming.
Okay, thank you so much. All right, so Dr. Anstey is going to come up and try to explain this relationship. It's not challenging. She has the most challenging talk, but the good thing is they're all pros, so they know the information. So it's a real pleasure to introduce you. Thank you, Dr. Anstey.
Yeah. Well, I'll just echo. I also want to be outside, but thank you for being inside with us today. So I will try to tackle this subject for you guys today, and then of course we can answer any questions shortly after this talk and then at the end as well as a group. So briefly kind of talking about what do we know about the association between food allergies and eczema? So to start, I just want to get us on the same page. Like, it's super common to consider what causes my eczema. Is it food? Is it in my environment? Is it genetic? What else is causing my eczema? You might ask yourself questions like, is what I'm eating causing my eczema? Is there anything I could avoid eating to improve my eczema? Is there any testing available to figure out these food triggers for my eczema? And we've already said it, but just to reiterate, individuals with eczema have a higher risk of developing allergic conditions. And these might include hay fever, asthma, and food allergy, all of which we see in our allergy clinic. And this is because of that similar immune system pathway that you've already heard a little bit about this morning. And we know that up to 20% of adults with eczema are also diagnosed with asthma. So it's just all of this interplay of very common immune system pathways and causing the same kind of conditions. So I base my talk off mostly like questions that you might have and then trying to answer them to the best of my ability. So one question that I frequently get is, if I have or my child has eczema, do they have a food allergy? Super common. So I want to kind of break this down of what I think about food allergy and what I think about eczema. So food allergy is on the left-hand side of the screen. These are immediate allergic symptoms to specific foods. And as Dr. McDougall just said, this could include hives, which are these itchy red bumps that you kind of see here, right? Key is they're being kind of immediate right after you eat a particular food. You might have swelling, often what we call angioedema of your lips or tongue. You might have immediate vomiting, difficulty breathing, kind of those specific symptoms. In eczema, instead, it's the rash that you've been kind of seeing. It's this delay, it's kind of a chronic condition that causes itchy, inflamed skin. And back to food allergy, we know that there's kind of mostly top 9 food allergens. And just to go over those today, that includes peanut, tree nut, cow's milk, egg, wheat, soy, fish, shellfish, and then the 9th, sesame. And so those are the kind of most common food allergens that we think of in this immediate type of food allergy. And we know that up to 15% of children have food allergy in the United States. So it's actually very, very, and quite common. Eczema we talked about, right? This kind of chronic, itchy, inflamed rash. And we know that about 10% of all people are affected by eczema at one time in their lifetime. And we know that it also starts commonly in childhood, as we've already discussed this morning. But food allergy, as you can see, does not equal eczema, right? So while food allergy and eczema can commonly be found in the same patients, right? We've talked about this similar immune system pathway. They are not the same disease. And the keys to kind of think about when we're distinguishing in clinic between the two include the timing of symptoms, right? Food allergy really should be immediate. The presence or absence of other kind of full body system symptoms of allergic reactions, like swelling, vomiting, difficulty breathing. And then the rash appearance as well, right? We said that that kind of rash appearance in that immediate food allergy is hives, right? Those big itchy kind of mosquito bite-like lesions versus this chronic red itchy rash in eczema. Okay, so another question that I commonly get is, what if I have or my child has symptoms of a food allergy? So certainly, your allergist will take a thorough history, and we kind of consider food allergy testing specifically to the foods that you have symptoms to. So let's say you have immediate food allergy symptoms to a particular food. Then we can consider either scratch testing or blood testing or potentially even both. And these are the 2 main modalities for testing. And you can see what scratch testing looks like on the upper picture. Sometimes we even consider oral food challenges in clinic as kind of another level of testing. Like if you were concerned about a food allergy, maybe we even give the child or the adult a food in clinic very closely and what's called an observed challenge and see if they have a reaction. Food allergy treatment, I'm just going to very briefly cover it. It's typically avoidance. So these terms of food desensitization and omalizumab are options, and hopefully more to come later this afternoon in Dr. McDougall's talk. Okay, so a third question. Is there any role for food allergy testing without food allergy symptoms? So food allergy testing in eczema solely. So food allergy testing should typically only be performed in those with a history of this immediate allergy symptoms to a particular food. So again, in an adult or child who has a particular food that is causing these immediate symptoms, that would be a food that we would consider testing to. And this next point is key. I get often like, why can't we just do a full food allergy panel, right? And this is why. Individuals with eczema are at a pretty increased risk of what's termed false positives in allergy testing. And that's because this is basically, to explain more what I'm saying, is that the adult or child doesn't have a true immediate food allergy, but they're testing as positive anyway, just because they have eczema and the kind of properties of the testing. And so this happens in both skin and blood testing, which makes it really difficult to then interpret if we don't think they have a food allergy beforehand doing the testing. Really, what do we do after that? And the other next, the third bullet point on the slide is also very key, because unnecessary food avoidance, like if we do allergy testing and it's positive, like it's positive, right? Because they have eczema maybe, right? But they don't actually have a history of an immediate food allergy. And so we tell them to avoid that food, let's say. That can lead to the development of actually food anaphylaxis, this immediate type of food allergy. I'm going to cover that more in a few minutes about what I mean in studies, and we definitely see this in patients. So, in general, just the key point is that routine food allergy testing is definitely not recommended to improve eczema control. One caveat, and I just take a step aside very briefly, is in children. And in children, early food introduction is key. And again, it's kind of hard to talk about in what order. So I'm going to talk more on this later. But the goal in kids with eczema is to introduce foods safely early. And so we know that in children with severe eczema who have not yet been introduced to peanut, that often we recommend peanut allergy testing to make sure that we can introduce that safely early. Okay, fourth question. Is there any role for food elimination diets without a diagnosis of food allergy? So we don't typically recommend food avoidance, right? We just said that a few slides ago in children and adults with eczema due to one, lack of effectiveness with this intervention, and then two, the risks associated with food avoidance. So this is a great study, and this study basically found 23 patients who developed a food allergy. They actually even confirmed it on a positive oral food challenge. So they took, I think it was 30 total patients, and then they confirmed it and made sure that these 23 patients that they included in this data actually had a true immediate food allergy. Now, this is key because these patients actually previously had been tolerating these foods. And you can see that many of these 23 patients had severe and frequent reactions. So they had severe enough reactions to require epinephrine, like anaphylactic immediate reactions were reported in 52% of these patients, and 35% of them experienced multiple episodes of immediate food reactions. Most had this, quote, atopic background, so other kind of these kind of conditions that we've been speaking about today. So eczema was diagnosed in 52% of these patients, and 78% of these patients had a marked personal kind of atopic or allergy background. And here's the key, most developed this food allergy as a result of an elimination diet, so 70%. So these patients were tolerating the food, stopped eating the food. A lot of these were actually told potentially by providers or just found stuff online. And then they actually developed a food allergy, even though they were tolerating it before. So in general, when do we recommend food avoidance? Really, food avoidance is always indicated if a child or adult has a diagnosed food allergy, other than if they're on food oral immunotherapy under the care of Dr. McDougall. But really, we don't recommend food avoidance for eczema alone. Okay, next question. How can I best prevent my child with eczema from developing a food allergy? The key is early food introduction of these top 9 food allergens that we've already gone through, right? So peanut, tree nut, cow's milk, egg, wheat, soy, fish, shellfish, and sesame. And we typically recommend the early food introduction around the age of 6 months of age. And this is based off of a lot of trials, but just to go over kind of the main one that I think and is brought up in a lot of these talks is the LEAP trial, which included a bunch of infants, 600 infants. And basically what it found is that infants who were avoiding peanut had an increased proportion of peanut allergy over those who were introduced to peanuts early on. And we have found in other trials outside of the LEAP trial that there's similar results with other allergenic foods as well. Okay. I'm going to pause there and ask if there's any questions.
How
Yes.
long would the food avoidance take to develop reactivity?
Yeah. In general, I mean, in general, we typically think of like a few months being a low enough time. So like 3 months is a small enough time to start developing those kind of immediate food allergies. That study that I quoted didn't necessarily it didn't say exactly how long these people were avoiding that particular food. Yeah, great question. Yeah.
This is a dumb question. Can you just give me your quickie definition of the word atopic?
Atopic, is that what you're saying? Yeah, no question is dumb, is what I always say, but atopic, so it's basically this group of conditions, which is kind of what Dr. Simpson was saying before. So eczema, seasonal allergies like hay fever, asthma, food allergy kind of sit within that kind of atopic, that same immune system driving inflammation that we've been talking about. Same pathway.
Even physicians and researchers always ask that question because I think technically it means without place, and it was such a long time ago when it was named because it was such a mystery and remains so.
I'd never heard of sesame being used before. What's the form of it? Seeds, oil?
Great question. So in general, when we talk about sesame, we're just talking about like sesame seed. I won't dabble into the oil question too much, but like basically sesame seed protein, which is typically found in like tahini, sesame seed itself, hummus is another common area that you'll find that used. Yeah. Yes.
Why would avoiding a food cause you to get allergic to it?
That's a great question, and that is a great point. So what we think is that we maintain tolerance when we're eating foods orally. It's a way that our body kind of maintains that tolerance to that food and doesn't develop an immediate food allergy. And so in general, avoiding it then kind of puts us at risk because we're not maintaining that tolerance by eating that particular food. Yeah.
If you can develop intolerance by not eating it, can you reverse that by starting eating it again?
Great question. So in the case of, I'm gonna kick that off a little bit to Dr. McDougall, who will hopefully share that a little bit in her talk in children. But if you truly have an immediate food allergy, really you should be avoiding it because you shouldn't be giving that to yourself at home, not in a clinic supervised arena, because you have a risk of an anaphylactic or severe allergic reaction. But there are kind of newer food allergy treatments like oral immunotherapy, where you can kind of train your immune system to tolerate a food under the direction of a food allergist. Yeah.
This is only if it's like an anaphylactic type reaction,
Right.
not like digestive issues or whatever.
Yes, correct. Yeah, and we didn't cover digestive issues today, you're right. Like food sensitivity or food intolerance is kind of what I call that kind of allergy. And you're right, there's not a ton of data on that kind of sensitivity or intolerance. Yeah. Sorry.
No.
Yeah, I've had this problem since I was a very young little girl,
Yeah.
and I've seen many doctors. I'm 73 years old. When is this going to be over?
That's a great question. I mean, that's probably too hard for me to answer. I will leave it to the dermatologist. I don't know, Dr. Simpson, if you want to say, you're talking about specifically eczema or food allergy? Dr. Simpson, you want to take that from the?
Yeah, thank you. Um,
I'm gonna step away.
No, we know there's predictors of that you can predict as a kid who has a risk for long-term condition, for long-term disease, where we know that some kids grow out of it. And so some of those risk factors that make it keep going is how severe it is early on. The development of multiple atopic or allergic conditions. So if you have eczema and asthma and food allergy, that kind of shows, and studies have shown that leads to longer term condition. And so we're actually doing a study for the NIH right now, looking at is there ways we can predict things? Can we predict, outside of those other factors? Can we predict who is going to have a poor, what we call prognosis, or long-standing disease? And I'm very interested in if allergy has shown us if what we do early on can matter long-term, is how we treat eczema early on. Can that change the natural course of the disease? Can we, as physicians and providers, impact that long-term prognosis with how we treat? And there's a really interesting article from a group from Japan, and actually showing the interplay between food allergy and eczema. Maybe you're going to talk about it, Dr. McDougall, or not. I'm not sure. The topical steroid or the topical treatment early.
I was not going to.
Yeah. Okay. So I'll just quick say, they showed that if you treat really aggressively early, they randomized, little kiddos who just started eczema, and one they kind of just gave a little bit of treatment here and there, and then the other one they treated very aggressively, almost like to a toxic level of topical steroids. But they showed proof of concept that when you follow those two groups out, they had lower food allergy in the aggressive treatment group of eczema. It's the first time it's ever been shown that you can kind of treat one condition and impact another, and impact the prognosis. Now, I don't recommend that, and the kiddos were smaller, lighter, lower weight because of the potential side effects from the topical steroids. But it is proof of concept that maybe we can alter the long-term course of all of these allergic conditions.
And to add to that, there are studies when we look at atopic conditions, so not just eczema, that kids who have environmental allergies, especially to dust mites, if you put them on immunotherapy, like allergy shots, you guys have heard of allergy shots when people have hay fever and you give them shots and desensitize them to the environmental triggers, it actually reduces their risk for developing asthma. And that's been shown both in allergy shots and sublingual immunotherapy as well. So there, again, this connection of if we treat their allergic conditions early, we could prevent a lot of other allergic conditions going forward. And so this all plays together, and hopefully we'll keep learning more that as soon as a kid shows any signs of following this pathway, if we can treat them very appropriately and aggressively early, we could prevent all these other things from happening in the future.
Follow up on that, you were talking, so you've been talking about treating aggressive early, helping later. That's with the knowledge we have now. If we grew up during a time when that wasn't the protocol and things were treated more conservatively over a long period of time with limited results, does that mean there's less likely that you're going to be able to turn it around?
You gonna kick that one to me too?
Yeah.
Sure, you do want to try, or?
No, you can.
Okay, I can try. So it's a great question. But I think long-standing condition probably, I wouldn't promise my patients that you're going to grow out of this soon, and I think that's a common refrain from pediatricians, dermatologists when you first develop eczema, and so it's very painful when that's not true. And so we don't say that. I don't think there's, so Dr. Dosha is saying she doesn't say that. So, but I think long-standing disease probably predicts longer-standing disease.
And we've learned more about asthma in the same realm, that we used to always say most kids are going to outgrow asthma, but even if those kids outgrow asthma, more than 50% of them will develop asthma again in early adulthood. So we're seeing this this falsehood of hey, we should just tell people that they're going to outgrow this because it's not always true.
We want to say it.
We want to say it.
And we want to believe it. But now we're realizing it's not.
So I'm curious, I'm hearing repeatedly, it's the chicken and the egg thing, the eczema coming first and then the potential for food allergy coming after. Well, I'm a living example of the reverse. So I have celiac disease, I have 2 other autoimmune conditions, and I didn't develop eczema until I was 56.
Yeah. I mean, we certainly, these are more main statistics, right, about how everything interplays, but this is not applies to every single person that has eczema. Yes, is the short answer.
Yeah, this has been a scientific question
Yeah.
for a long time, and so there's not too many people know this study. There's a researcher, Andrew Lowe, in Australia, and he followed a group of kids that were high risk for eczema, meaning they had their family history of asthma or eczema, and then wanted to ask the exact question that you just asked. So it's just amazing that this audience is coming up with scientific questions that people who've been doing this forever have asked and are trying to ask. And so he wanted to know, is food allergy before eczema or is eczema before food allergy? Which that might tell us what's causing what. And so they found that there was 50% of kids had food allergy first and then developed eczema. So they're okay, that's interesting information. But then when he kept following the kids who didn't, it was the kids who had eczema later, who had eczema first, then they started developing food allergy. And so it was there wasn't one that was definitely causing the other, because if you didn't get the eczema, you would end up getting it later or vice versa. So it was just all over the place. So they kind of are risks for each other.
Is there a difference between food intolerance test to IgE, or are they the same test?
Great question. So they are different. So immediate food allergy testing as scratch, and then IgE blood allergy testing. Food intolerance testing that you frequently will hear about is IgG. That's a difference than IgE as an elephant, IgG as in girl. And that's typically a blood test. And that has not been proven in studies to suggest what people are intolerant to. And so we typically recommend against that type of testing. And instead, if a patient, if we're worried, a patient has a food intolerance, let's say a lactose intolerance, is maybe avoiding lactose or something like that and trying that out first. Now, everything comes with risks, right? If we're avoiding a particular food, that's a risk-benefit discussion with the patient. Yeah. Sorry. Yes, you.
So I have a 15-month-old boy, and he's been diagnosed with eczema and allergies. So when he was 9 months old, I gave him peanuts, an Indian form of peanut, whatever. So what happened was he had hives immediately, but within 20 minutes, I didn't know anything and subsided of myself. Then when we did the allergy testing, the blood test and skin test, it came positive, and I've stopped giving him since then. What do you recommend that I should do?
Yeah. So I think that the key is that it sounds like your son, right? Yeah. Your son had immediate symptoms to a common food allergen, and then your allergist did food allergy testing, right? And so in general, the next step is food avoidance. Now, there's a lot of caveats there, as in if you're doing food avoidance, you should repeat allergy testing about every year to monitor that food allergy. You shouldn't just say, my son has a peanut allergy, here's an EpiPen, never think about this peanut allergy again. But also, our food allergy center, which you'll hear more about from Dr. McDougall, has different options as far as food oral immunotherapy, which are kind of ways to get people to tolerate a bite of peanut, for instance, and prevent severe allergic reactions from accidental exposures to peanut. Yes. What is your age limit, Dr. McDougall? I don't know.
12 months.
12 months. Okay. But she'll talk more about it, I think, in a few minutes.
Okay, I have another Yes, yeah. So, one of the things that I observed was in the blood test, the IgE levels for peanut was the lowest, it was just 0.97. The almonds and cashews was like 3.5 or whatever. He's not allergic to almonds, and at least I don't see any reaction because I've been giving it to him from 6 months. But peanuts being the lowest, he has shown the greatest reaction. So how is that, like the IgE value is high, but the reaction is,
Yeah.
I don't know.
And I think that totally brings up the key of like that high chance of false positives, that not having a true allergy, right? Like your son tolerates almonds, but the allergy testing is positive. So it's a false positive, right? The allergy testing shows a positive, but he actually tolerates almonds. And the best thing that like what is the best way to test a food allergy is that he tolerates the food. So he's not allergic to almonds. Does that answer your question though? Does it mean anything that the peanut's lower? Not really in my mind. If we combine most scratch testing and blood testing and the history to kind of move forward about the discussions about food avoidance or a challenge in clinic to peanuts. Yeah.
When he reacted to peanut, it was, we did not do anything, it subsided by itself, right? So I was wondering, should I introduce it to him because it did not really go beyond 20 minutes? Or maybe because I'm avoiding it now, will we be at higher risk of developing even more worse allergy?
Great question. So I would never recommend introduction of a food that a child has had hives to with positive allergy testing at home. That's just never something that we would recommend as allergists. But you could speak to your allergist depending on the allergy testing and the scratch and the blood testing results, whether you could do like a graded challenge in clinic and see if he's outgrown it or repeat allergy testing now. But yeah, never introduce it at home and just hope, because like, even though the first reaction was just hives and just lasted 20 minutes, the next reaction could be EpiPen or something like that. So you never want to do those tests at home. Yeah. Yeah. Yes.
So we're talking a lot about things that people need to avoid.
Yes.
But when it comes to eczema and not necessarily the food allergy side of it, are there biochemical therapies, like do you need to do a certain set of vitamins to help improve the skin barrier, the microbiome? Why is that not more of a discussion when I've gone to several different dermatologists for eczema, and it's always like, here's some corticosteroids. And I feel like it's putting a Band-Aid on the problem, and then that then causes more problems. So how is all of this together working on addressing like what is missing from our diets that's causing this emergence of all of this inflammation in everyone?
Yeah. So you're talking more about kind of like not food avoidance, but what can I like add to my diet to like do it? I'm going to pass this off to Dr. Simpson. I have not seen any studies on supplements or vitamins. I don't know if you've seen any studies on that.
Guidelines, and this is and this is part of what we can talk about in some of the Q&A online for like just general big eczema questions like that. It's an excellent point, and there's and we still don't know how to address the underlying cause. And of course, patients and physicians and clinicians want low toxic ways to, and so I'll just give you one example in terms of we have no evidence-based kind of recommendations on those. And meaning at the highest level of evidence, randomized controlled trials that vitamin X, supplement Y can improve even any part of the condition actually. And I'll just give you an example. So we know the microbiome is abnormal. And so the NIH worked with, and we try to figure out, well, what's wrong with the microbiome? Can we correct the microbiome? And can't do it by supplements necessarily, but these researchers at NIH found that a very beneficial bacteria is gone in patients with eczema. Okay, so this Roseomonas mucosa, it makes these metabolites that are anti-inflammatory, anti-staph, and they put it on kids and adults with pretty severe eczema. Actually, we'd spray the bacteria, these healthy bacteria, try to restore the microbiome. And it was amazing. I mean, and it's in the highest impact journal. So, you know, we're going to cure eczema because we can change the microbiome. And so we got involved with designing like the next level of evidence. We had to have a control because we were just spraying, and you know, it seemed to really help. It was amazing. But when we subjected it to the highest level of evidence, we just finished this. It was extremely disappointing. Control group was fake spray, or like a spray which is water, and the other one was with the bacterium. Zero effect. So there's a lot of work. There's a lot of work being done. It was devastating. Broke my heart. I thought I thought we could spray before, you know, eczema starts and prevent it. But we would have to use those highest level of evidence to recommend to patients. At least this is my perspective. And I'm willing to say, boy, my hypothesis was proven wrong because it was subjected to this level of study. And we did.
The Good Skin brand or like the.
I think there might be a over-the-counter version of it. Yeah.
I think I read about that where there was a brand that was marketing itself as a microbiome for your skin, and then it had been proven wrong.
Right. So there are studies looking at. We just don't have. Nothing has been positive where I can give evidence-based recommendations to a patient.
Understood.
And this is very similar with other atopic conditions because we know the microbiome specifically plays a big role in a lot of these atopic conditions. And the problem is there are studies that identify that there is a difference between patients that have asthma who don't have asthma and what their microbiome looks like. But to change their microbiome and actually for that to stick, first of all, and then two, for it to actually make a clinical difference are really high barriers and really difficult to get that level of evidence. And so these things are being studied all the time. We are not sitting around here saying, what kind of topical steroids can we look at next? Like, there are a lot of these studies that go on in the background, and unfortunately, because a lot of them end up not meeting our hypothesis, they don't get published widely, right? It's this bias that if it's a negative study, we're not going to tell everybody. We don't want our company to go under. And so you don't hear about all of these studies that happen all the time, because we would love that too. We don't love just giving everybody steroids and being like, that's the best evidence we have. But luckily, over the past 6-7 years, we have all of these new medications now for eczema. We just got our first food medication approved ever, really, outside of immunotherapy, like 3 weeks ago. So like this stuff is moving. It seems like at a glacial pace for a lot of people, but it's really because we want to make sure it gets that level so we can feel confident that when we give it to anybody, that they have a better chance of it actually helping than doing nothing. We don't want to give snake oil. We really don't.
And it's same in the food allergy world too. There's a huge push for studies looking at prevention because we know even early food introduction, there are kids who are already allergic to foods prior to the time that they'd be introducing at 4 to 6 months. So there's a huge ongoing cohort study called Sunbeam that's looking at what factors could be a role between, they're looking at moms starting when they're pregnant with child, taking blood work, looking at things, and then they're looking at the kid at 0 months old and then 1 month old, and then they're coming back at 5, 12, 24, 36, and they're trying to expand that. And then they're really trying to look at could probiotics or something else prenatally or postnatally help. So I think there's a lot of interest in what can we do so that we never have to like worry about what the next step is for oral immunotherapy or the injection medicine that's now available for food allergy. But we are definitely interested in that. It's definitely being studied.
Your tax dollars, thank you. And, you know, NIH is funding these huge, you know, hundreds of millions of dollars in trying to figure this out.
I have one last question. I don't know where I'm at.
Yeah.
So you may have answered this question earlier, but when you talked about sesame, was that sesame seed? And if it was sesame seed, does that mean that you would be also, if you're allergic to sesame seed, would you be allergic to tofu? Would you be allergic to soy sauce?
Great question. Okay, so the question was more about kind of that sesame question. So I would say that so sesame and soy are two different food proteins. So if you are allergic to sesame, you should be allergic to like anything that's labeled with sesame. So on the back of every food product in the United States is the top 9 food allergens. Sesame is now included and should be included on that label. Sesame is different than soy protein, tofu. So they're very different entities. Soy is the legume and sesame is a seed. Does that help?
So sesame oil,
Yes.
that would, if you were allergic to sesame seed, you'd be allergic to sesame oil.
Yeah, so in general, it just depends on, and I'm gonna fudge, I guess, like, you know, span the 2 gaps of this question. So a really, really well refined oil probably doesn't have a lot of protein, and the food allergen is typically found in the protein. So, but in general, I still recommend people avoid oils with that caveat of it being ultra refined might not lead to symptoms because there's no protein in it. Yeah. Yes.
What can you use if you're supposed to avoid soaps as an alternative?
Oh my goodness. What can you use if, well, so in general, I would recommend, you know, like we were talking about earlier, like a fragrance-free, dye-free soap if you need it in the areas that you need it. So, you know, for a little kiddo, we're talking about only using it in their armpits and groin and maybe shampoo every once in a while, not like a daily full lather. And for adults too, trying to use minimal soap, wash it, you know, if you're taking a shower, washing it off right away. If you're taking a bath, leaving it until the very end and kind of washing the areas that you need to have washed rather than just lathering yourself in soap everywhere. No fragrance and no dyes, like no color additives. So really it should be totally fragrance free and totally clear. Do you guys have any other like specific recommendations that you typically make?
It'll be an individual like kind of discussion because there's also some things that are all natural or dermatologist recommended that are like not great ideas either. But and I don't consult for CeraVe or Cetaphil, but you know those are decent. They have a lot of chemicals in them, but nothing that can cause allergy, and their pH is okay. So yeah, it's kind of I could do like a 2-hour session on cleansing. So hopefully we'll put some information on the website for that. Okay, so it's my honor to bring up a caregiver of a child with eczema and food allergy, who's going to kind of share their story with us, and Dr. Joshi will be asking the questions. So thank you so much for being here.
Want to come in?
Yeah, I think they'll come in. I just texted him.
Why don't you guys sit over here? So thank you, Sam.
Cheers.
So this session is really based off of the NEA. So they have a lot of fantastic patient experience sessions, and I feel like those are the most impactful sessions at the National Eczema Association meetings. And so this is the first time we're trying this, so we'd love feedback on, is this worthwhile? Is this helpful? And first I want to thank Jack over here, who is going to be a trooper as long as possible, but is probably nap time soonish. So, yeah. And we're just going to go through a little bit about, sorry, I know I'm behind this podium a little bit. Let's move up a little bit. About their experience with eczema in childhood and food allergies and how that process is really difficult. There's a lot of information out there. There's a lot of good information. There's a lot of not so great information, and how navigating that can be really difficult and how that affects the family dynamic, how that affects individuals. And so, all right. So if you guys don't mind just introducing yourselves really quickly and kind of, are you guys from the area? You're not from the area, and just a little bit about yourselves.
Yeah, my name's Kat. I grew up in California, moved to Seattle. We met there, and then we lived in Chicago, and now we've been here for about 2 years. A lot of my family is here.
I'm Eric. I grew up in Ohio, met Kat in Seattle, moved to Chicago. Now I'm here.
Coincidentally.
Yeah.
Yeah.
And this is Jack. You want to say something? You say hello?
Jack is 15 months.
All right. And so when was Jack when did you first start seeing his skin change?
He was about 7 weeks. And yeah, he just had a persistent rash on his face primarily. And I think it was mostly just on his face. Oh, there's a little bit on his arms maybe. And so it wouldn't go away with just Vaseline or just typical moisture. And so then it was diagnosed as eczema.
Okay. Did you notice that his behavior changed at all, or was it bothering him at all?
Yeah, so there was definitely a period of time around 3 or 4 months that he had it really bad around his eyes. And we, being new parents, were like terrified to put anything near his eyes. And so we thought we would like avoid. We had a prescription for tacrolimus for his face, and we were like, oh, we shouldn't put it on his eyes. And finally spoke to the doctor, and she was like, maybe you can put it like a little close, but he would stay. It was really hard for him to sleep, so we swaddled him as a newborn, and we ended up swaddling him longer probably than most people do, because he would keep himself up scratching his eyes, and then if he was swaddled, then he would fall asleep and the itch would go away. But it was really tough either way, because it was just hard to see him be super itchy.
And he would, just like most of the time, sitting around, lying around, he would be kind of scratching and itching, and he would feel new textures for the first time with like this motion, just because we think, what he was doing all the time on his skin, and then he'd feel the ground and just do that, and it's kind of cute and kind of sad.
Do you guys have any family history of eczema in the family, or his siblings? I guess he doesn't have any siblings right now.
Yeah, he doesn't have any siblings, but yeah, I don't have any history of eczema.
Yeah, I mean, there's nothing like diagnosed in my family. I have very sensitive skin, dry skin. I never thought of it as eczema, or never turned into eczema, but some of the stuff he has is like familiar to me from being a kid, but never really did anything about it.
Yeah, just a couple weeks ago, Eric was like, so when you scratch and itch on your skin, you don't feel like there's a timer of when it's going to get worse? And I was like, no. So it seems like maybe there's something going on. Yeah.
So when was the first time after you started developing these, the changes in the skin, did you first bring it up to the pediatrician?
Right away.
Okay.
And we saw a few different pediatricians about it, just because his actual pediatrician is harder to get in with like sick visits. So it was just a few different opinions by nature of that. So I think it was maybe the third time when we went back, and it was like, this really isn't going away, that it was diagnosed.
Yeah, physician access is a whole different story that we will not be solving today.
And I think originally, because it was like in the winter when we were first noticing this, and kind of our first theory was like, well, when the weather turns, and it warms up a little, it'll probably go away. And it didn't, obviously.
He definitely has it where the warm weather makes it worse. So.
And then it sounds like you saw dermatology soon after that?
Yeah, so we were referred to a dermatologist, not pediatric at the time. We've since switched over here, which is awesome. But yeah, so we went to a dermatologist, and they kind of got us on a routine of 3 different prescriptions that we do with him, just kind of depending on severity and flare-ups and area of the body, time of day, all that.
And so through this process of seeing a pediatrician, seeing a dermatologist, how did your understanding of what eczema was change, or did it change?
Yeah, it's a good question. I feel like, I don't know. I guess something that was new that I didn't know about was when he would get sick, that he would have flare-ups. And so that was kind of, that has helped us actually. He's in daycare. So when we see him have an eczema flare-up, and if he has like a little bit of a runny nose or something, we're like, something's coming, as opposed to before we would just kind of think like, oh, who knows, he might this might be a lingering runny nose. But now it's kind of a little like alarm bell, like maybe we shouldn't go see my parents this weekend if something's brewing in there.
And outside of speaking with your physicians or your healthcare providers, what other sources of information were you looking at to learn more about eczema? and treatments?
Yeah, I mean, we try to avoid Googling as much as possible.
It's Baby 411. We
yeah.
check that for a lot of stuff.
I'm a big fan of Emily Oster, who's a economist who talks a lot about parenthood and data surrounding that, but she doesn't have a ton. She doesn't really specialize. She's more of a generalist. So I would look stuff up and try to find anything about eczema there. And we would talk to a lot of our friends with kids. You know, their kids had a little bit of eczema at one point or another. But yeah, no. So at the very beginning, I would talk to them and kind of be like, oh, what did you use? But it was often the, like, here's a very, you know, mild over-the-counter thing that totally worked wonders.
Yeah,
and
like
then we were like,
right
this
out.
didn't do anything. So,
Yeah, I think everybody has a little bit different experience and severity, and each kid's different. And there's not going to be a one size that fits all, unfortunately, that we've discovered yet. Okay, so then we're on this eczema journey. And when did you first even come up that he may have a food allergy?
yeah, so right when he started daycare, I was breastfeeding and then decided that I wanted to try to supplement with some formula so I didn't have to pump as much at work. And so I asked his pediatrician about it, and funnily I was like, what if he's allergic to formula? And she was like, unlikely, just try a regular one, like, you know, we'll see how it goes. And then we did, and then of course he had like full body hives within an hour. So that was when we found that he had a cow's milk allergy, or that was this, you know, suspected. And so then that's when we so she prescribed EpiPens for the future, and that was kind of the start. And then we didn't see an allergist yet, so she said it's probably okay to wait since milk is such a common allergen or allergy in kids. And he was about 5 months old, and then I think it was around 6 months old, we introduced Peanut. And he had just a very mild rash around his face. So we, you know, we're like, okay, noted. This is probably an allergy. We'll hold off. And then, like a few hours later, when he was in bed, he just projectile vomited all over. And we ended up using Epi after being on the phone with the doctor because he sounded kind of hoarse too. And with a baby, it's just really hard to tell if he's swelling or what. And then we spoke to his previous allergist, or we got hooked up with an allergist and did some testing and found egg came up positive on that first skin test. And then since then, we did some more skin testing as a result of him coming home from daycare with hives randomly. We didn't know what it was, so they did some more skin testing and nothing came up positive. So then we did some more introduction. We introduced sesame at home, and like we would like set a timer for 10 minutes when we introduce a common allergen and give him just the tiniest amount and then see what happens. And by the time the timer went off, we'd already administered Epi and I was already on the phone with 911 because he had like swollen lips and hives. And then we did and that had been negative on the skin test. And then we did cashew in office at his old allergist, and they like just did the little like swipe on his lip to test it, and then they needed to give him Epi within 5 minutes for the same type of symptoms. So, and that had also been negative on the skin test. So that's
And then he didn't really like for a week after that he didn't eat solid foods.
So yeah, that's
the journey. That sounds like quite the journey. When you had to use epinephrine for the first time, what was going through your mind? Was it scary? Were you like confident about it? Or?
No, it was really scary. I mean, I had been trained in it, like working with kids when I was younger, but I had never had to use it. And he was just like projectile vomiting all over the living room while I was on the phone with the nurse line or with 911. I can't even remember at this point, but yeah, it was really scary. It was just like, is he going to be okay? I don't know. And it was also really hard to just give it to him. He was so tiny at the time, and like, you know, his mom coming at him with this like forceful thing. I will say that since then, I think we've been really calm in the moment. It's nice to know that there is a thing we can do and we know how to do it.
I think having that first experience where it ended up like the reaction maybe wasn't as severe in that moment. Having done that and like had the ambulance come or, fire department, and then going to the ER when it was a severe reaction, it made that a lot easier, I think.
Yeah, definitely.
And so with the cow's milk allergy, did that affect your decision to continue breastfeeding? Did you have a certain thing in mind, and did that end up changing because you were worried about giving him formula?
Yeah, so we did. I didn't have a specific plan of like, let's get on formula and do it this amount of time, but it did just, I was just like, well, never mind, we'll keep breastfeeding full time. And I mean, I work from home, so that helps a lot with pumping and everything, but we had tried soy formula, but then he had soy formula the same day as the peanut, but he had had it before, like peanut was the only thing new that day. But there was some question of if he had FPIEs for soy formula because of the delayed vomiting. He's since had soy and he's fine, so we think that's okay. But and then I think, did we try any other formulas? I think those were the only two we tried. Also, they're just so expensive when you don't have just like not the regular cow's milk ones.
And there's a shortage of them for a while too.
Yeah.
And so it's tricky.
Yeah. So yeah, it did definitely affect it. And there's a lot of peace of mind of being able to breastfeed and know like I can feed my baby regardless. Like if he was allergic to literally everything, breast milk seems fine, so I could feed him. So it was definitely, he's now weaned, but I hadn't been planning to breastfeed him after a year, and we ended up going to about 14 months. So yeah.
So she mentioned FPIEs, just for people who don't know what FPIEs is. That's food protein induced enterocolitis syndrome. It's a different type of food allergy that's not IgE mediated. So the testing that we can do, skin testing, blood testing, not helpful for this type of allergy, but it does present with a delayed vomiting in kiddos. So they vomit and vomit and vomit and vomit and vomit. It's not a one-time vomit situation, but it's usually 1 to 4 hours after eating the food, and they continuously vomit. And so it's terrifying to watch your kid vomit that much. It's not what we considered a life-threatening allergy, but it is a terrifying allergy. These kids can get really dehydrated, and so because of the delayed features of the vomiting, that was definitely considered in there as well. Daycare. So food allergies and daycare is always a tricky discussion. And so how did you have that discussion with your daycare, and do you feel like it went well? Do you feel safe with sending him to daycare still?
Yeah, we do. I think we're really lucky. They're really well trained, really knowledgeable. One of his teachers actually has an EpiPen herself and has had to use it on herself. So like, as much as I don't wish that on her, it's peace of mind knowing that she actually knows kind of what it's like. And I think the discussion, it really just kind of ramped up along with our own understanding of allergies and the severity of his allergies. So it started as just like, FYI. And then it became like, here's our full list of everything he's eaten that's okay. And so now we just update that list. It's like an iPhone note that we share, and they have it printed on their kitchen, and they're the ones that provide food, but they're open to it if we ever want to switch and provide food ourselves. But they don't introduce any new foods there. They were for a while. We were comfortable with that before we knew kind of how many, the nuts and everything and the seeds. But now they just only give him exactly what is on the list. And we'll send, we just found a new snack bar that he doesn't have any reaction to. And so we sent them a picture of exactly that and exactly the ingredients. So we feel pretty comfortable.
And I think we're lucky in that one of their things is just feeding like generally whole, simple foods to the kids, which they get themselves. And so a lot of times it is like single ingredient foods they're feeding rather than, like processed bars and stuff that might contain a lot more stuff. So that's made it a little simpler for us, I think.
Yeah.
How much time do you have, Karma? Okay. So part of the discussion of today has been kind of the interaction between eczema and foods. When you were going through that eczema journey early on, were you instructed to, or did you try any food elimination? How did that go? How was that stressful? Was that easy?
I did a little bit of elimination myself when I was breastfeeding him, and just kind of as an experiment to see if it affected his eczema, and that didn't for us. So I just continued eating it, and I was told by his allergist like it could be helpful if he does get certain proteins through the breast milk, then it could, be like his own little immunotherapy, I guess. But we didn't do any elimination for him. I guess when he was diagnosed, he wasn't on solids at all.
That's right.
So,
Yep.
Yeah.
Okay. Those are the main questions I wanted to go over. Is there anything else you guys wanted to mention or chat about?
I mean, you did just recently remember the nuts you were eating while breastfeeding him.
Oh, yeah.
His eczema and stuff.
Yeah. Yeah. I mean, since we've heard about how eczema could actually let in the proteins and cause the allergies, I've like thought back to the things I was eating when he had flare-ups. And yeah, I had like trail mix beside the bed, and we'd eat peanut butter toast, and then we're like kissing his cheeks, and it's just like, oh, I don't know. Who knows?
We're never going to know.
We're never going to know. Yeah.
And it's really, even the research on that is still pretty thin. It's a lot of theory on that this could be an explanation, but there's still not great data that this is the way. And I think we always tell as allergists, we always tell the parents, like, no matter what you have done, what you did, or what you could have done, the kid is probably going to end up with food allergies. And so never to blame yourself, because honestly, we don't know enough to tell you that one thing you did made a big difference. But I feel like always parents feel like they could have done something different and really couldn't. We don't know.
And yeah, I guess the other thing I'm thinking about too, kind of along those lines of like the choices, is there's just so many, and we talked about this, like like we were well aware of. Yeah. Yeah. We were well aware of early introduction and trying to, before he was 4 months, we were thinking like, 4 months, let's do it. But then he had some developmental delays, and he wasn't really ready to sit up and eat until about 5 or 5.5 months. And I think there's just, there's just so many factors to helping a kid learn how to eat that like we couldn't really introduce foods until a little bit later. We still hit the 6-month mark, but there's just a lot of stress in that, figuring out like a lot of cost benefit, and that's been a challenge, and something that and even with introducing new foods to him, we really only have the weekend to do that at the moment, because we don't want to do it at night before he goes to bed, and we don't want him to do it at daycare. But then if he's sick, then we're like, well, we're not going to do it this weekend.
That's so true.
Or if we're busy, and it's like, well, we don't have time to go to the ER today. So yeah, it's definitely a challenge.
And even in the study that Dr. Anstey had mentioned, the LEAP study, there were kids that even if introducing it super early, they're already allergic. And so we know that and even kids that weren't allergic and we introduced the food, some of them still became allergic. So early introduction is great. It helps, but it is not foolproof. And so introducing it at 5.5, 6 months, like even if you introduce it at 4 months, there's a probably good chance that he would have ended up being allergic either way. We're not going to take questions specifically for this session. We're going to do some question and answer after lunch. Is that right? Okay. So Dr. McDougall. Okay. All right. So lunch. Then Dr. McDougall is going to talk about immunotherapy, and then we'll have some time for question and answers at the end. But just want to thank Jack and his family for really spending some time up here and talking about their journey. So thank you. Yeah.
Comfortable the longer he's up here. We're gonna hire him here.
All right, guys, so you can go out either door, here or there. We have lunch set out in the back. We'll have about
20 minutes to eat and we'll play some videos while you guys eat, okay? You're welcome to bring your food back in here.
We can bring it back.
Yes.
And then there's bathrooms along this back hall.
Yeah.
Hi, my name is Ash. I'm 10, and I have eczema. Do you have eczema too?
I'm 8 years old and I have eczema. My name is Zachary. I have eczema too.
It feels good that I'm not the only one. Did you know that 2 in 10 kids have eczema, just like me and you? See these cracks, red marks, and oozing rashes on my arms? That's eczema, and I've had it my whole life. It wasn't always this bad, but it sure does make me itch a lot. Sometimes I can't sleep because of it. And yesterday, I woke up with blood in my bed again because I scratched so hard while I was sleeping. Now, my skin really hurts. And that's on top of the dry, flaking skin I usually have. When you have eczema, other kids are sometimes afraid they might catch it, and they don't want to come close. Good thing you and I know it's not contagious. I feel the best when I have long sleeves and pants on, even in the summer. That way, no one can see my marks and make fun of me. I miss swimming the most, but I don't want to take lessons anymore because my bathing suit shows my spots. Plus, water stings. But guess what? My mom is taking me to see a new eczema doctor today. I'm really excited. Oh, there she is now to pick me up. Come on.
Hi, Ash. I'm so happy you came to see me today. I'm sorry you've been struggling with your eczema. You're not alone. The good news is I can help, and I'm here to teach you and your family how to make your eczema better. Does that sound good to you?
Yeah. Hi again. This pool is so much fun. I look a little different now because I'm wearing shorts and a t-shirt, and all my spots are gone. Turns out my new doctor was right. Now, I sleep through the night. I can wear whatever I want. No one is scared of catching something from me. And best of all, I'm taking swimming lessons again. I'm so happy. And you can be too. Because there are amazing creams available. And if those don't work, there are lots of new things to help kids like us. Tell your parents and don't give up. There are lots of doctors out there who want to help.
With my new medication, I'm no longer suffering from eczema.
My doctor helped my skin so much. I can play with my friends. I can sleep through the night.
I'm Regan's mom, and Regan is so much better now than she used to be. Her quality of life is way better than it was. What can you do now that we couldn't do before?
I could go in pools to go swimming.
Right.
Dye my hair. I also get to sleep.
It's easier to sleep.
Yeah, it's easier to sleep and it's not itchy for me.
We're not itchy. The fact that Regan's not in a flare is life-changing.
Hi, we're the parents of Zachary Wu, and we would like to share with you what he has been going through this past year with his eczema.
Now that his skin has gotten a lot better, he's sleeping throughout the night. He has a full energy for school and playing with friends. He's able to kind of shower and clean up and without any problems and just live a really normal child life, which has been a big blessing. So we're really thankful.
Dr. McDougall, and I just want to say thank you especially to Camp Blue Spruce and Melissa for sharing where you're getting your lunch from Pollo Norte. It's a local restaurant in Portland if you guys are interested. Yeah, just thank you all again.
Thank you so much. And just in case I forget, I want to thank Karma for setting up this entire conference, as well as Rebecca Field, who's out there. So thank you so much. You guys are doing an amazing job. And thank you to our AV team from OHSU for doing a hybrid event, which is always extremely complicated. So thank you. Thanks to you guys for all that support. Okay, I think everyone's got their food. And I know no one's going to complain about leaving early. So shall we start? Okay, let's, why don't we have Dr. McDougall now come up and talk to us about potential treatments for food allergy.
All right, hi again, everyone. Hope everyone's enjoying their lunch. It looks delicious. I'm definitely gonna get some after this. But I'm here to talk about treatment of food allergies and what's available. So I think number one, it's important to start with, there's currently no cure for food allergy. And speaking to a question that got asked earlier of where, say we have eczema, we decide to eliminate a food, and then we were previously tolerating it. A few months later, now we're allergic to it or having a food allergy to it. There's a chance that you're not gonna outgrow that allergy, and there's not a cure for it. We know that a majority of people will outgrow milk and egg allergies, but peanut, tree nut, seed allergies typically are gonna be lifelong. The mainstay of our treatment, no matter what you're doing, even if you're on something like oral immunotherapy or an injection medicine, you still have to avoid your food allergen, and you're still gonna carry that EpiPen in case of a severe allergic reaction to that food. So what therapies are available or what is being studied for food allergies? So we think about having kind of four main groups right now. The first being oral immunotherapy, or OIT for short, sublingual immunotherapy, or SLIT for short. We have epicutaneous immunotherapy, or EPIT, which is essentially a patch that goes on the back, and we'll talk about. And then Xolair, which is an injection medicine. Of these, only two of them are FDA approved. So that includes Palforzia, which is a peanut-specific oral immunotherapy product for ages 4 to 17. And then there's Xolair, which Dr. Joshi had mentioned earlier, was recently approved a month ago. And that's for multiple food allergies. There's OIT and SLIT for many different foods, depending on the clinic you're in. It's just off-label. And then for right now, the patch is still undergoing safety testing, and so is not clinically on the market yet. I think the important thing to remember about all of these therapies is the goal is not to cure the food allergy. The goal is not going to be that the child or the adult is going to be able to eat this food whenever they want. Instead, it's what we call desensitization. And what does that mean? It's essentially allowing for a level of protection or bite-proof protection from that food, so that if your child or you were accidentally exposed, you would have a lower chance of having a reaction, but it's not going to allow you to eat a peanut butter and jelly sandwich if you have a peanut allergy. But maybe if your child got a hold of a cookie at a birthday party, they wouldn't react like they normally would. So let's take a closer look at these different therapies. So the first step is oral immunotherapy. And so what is OIT? It's essentially where you're eating, starting with very small amounts or doses of that food protein. It's usually going to be in a powder form or a liquid, depending on what the food is. For example, peanut powder or liquid for milk. But you're coming to your doctor's office, they're starting you with a really small dose. And then every day you're doing that dose and coming back every 2 weeks to slightly increase that dose until you get to what we call maintenance dosing. And that depends on the food. For peanut, a lot of times our maintenance dose is 300 milligrams, so essentially one peanut, versus maybe for egg, you're trying to do 1,000 milligrams. When I talk about this and counsel my families in clinic, I really want to get the nitty-gritty details of OIT because it's not an easy therapy to do. It's not something that's super simple for families. And so essentially when you're going home and doing this therapy at home, you want to schedule it the same time every single day. It's going to be with a meal. So I usually recommend dinner because then they're not going to school or anything like that. You have to limit activities when you're doing it. So 30 minutes before, 2 hours afterwards, your kid's not taking a hot shower, they're not exercising vigorously. It's 2 hours before bedtime, and you have to do it consistently every day. And so the older the child gets, sometimes this becomes harder and harder for families to do because kids have extracurricular activities. They're very scheduled. They're playing music, or they're at a sports event, or they're automatically going to be exercising for dance or something. And so then it makes OIT maybe a little bit harder for those kiddos to do. But the goal ultimately is, again, studies have shown that this can help provide a level of protection from accidental exposures to the food. But once this treatment is stopped over a period of time, you're losing that protection to the food. So ultimately, we think of it as a lifelong therapy or a long-term therapy. So you do it for as long as it makes sense for your family and you need that protection. Maybe once you get to a certain age, you're better about avoiding your allergens. You may not need it anymore. And so people will stop it and they lose that protection over time. There's a risk for adverse events with oral immunotherapy. You're giving your child or yourself something that you're still allergic to. And so the most common symptoms being belly symptoms for kids, so belly pain, nausea, vomiting, but you can also get hives. You can get severe allergic reactions with your dosing, which is why we have those really specific rules when you're giving the dose about no exercise, no hot showers, you're avoiding these certain medications, et cetera. So there are kids that have these adverse events. There are kids that have to use epi at home. And so you may have a family that's really adverse to any symptoms happening for their child. And so OIT may not be what we want to give them. Next up is sublingual immunotherapy. So it's slightly different than our oral immunotherapy. With our oral immunotherapy, we're using that powder, we're digesting it with a meal or an applesauce, whatever we've mixed into. It's going into the gut and hopefully developing some tolerance to it. Whereas sublingual immunotherapy, it's a daily treatment still, but it's placed and held under the tongue for 2 minutes prior to swallowing, with the idea that it's getting absorbed under the tongue and it's going to specialized cells in your body that help create tolerance. I think the hardest thing about this treatment is when we're doing it on really, really young kids. It works well, but when you have a 1-year-old and you're telling them to hold something for 2 minutes under their tongue, that can be an issue, right? I think it'd be hard for me to hold something under my tongue for 2 minutes. But in the research studies, they've still done really well with it. Similar to OIT, you're going to build up every few weeks until you reach your maintenance dose. And then again, if you discontinue, there might be some length of time where you're protected, but you're going to slowly lose that protection over time. Maintenance doses are much lower than what you see with OIT. So in OIT, we have like a 300 milligram dose for peanut every single day. For SLIT, it's 4 milligrams, which ultimately we know that it still is effective at giving you that protection, but it's safer and sometimes more well-tolerated than something like OIT. The side effects are typically mild. They resolve usually without treatment. And the most common symptom is going to be mouth or throat itching. And so then we may say, okay, well, why isn't everyone on SLIT instead of OIT? SLIT has only been well studied in peanut and it's not readily available everywhere. And we are also still figuring out, does it work the same way for other foods? We're not sure yet. We're trying to determine those things. And the other thing is it's not as cost effective as OIT. My OIT in my clinic, I'm using PB2 powder off of Amazon. It's very cheap to do. It's very affordable for parents and patients, but SLIT is extract and that costs a lot of money, and allowing that, having something that can be cost effective for everyone is super important. So what about epicutaneous immunotherapy, or EPIT, which is that peanut patch? Essentially, it's intended to be worn all day on the back and replaced daily. Unlike OIT and SLIT, which require you coming to the office and updosing every 2 weeks and you're getting higher and higher doses, instead, during the first few weeks that the kid is on the patch, you slowly increase the time during the day that they're wearing the patch. It's been shown to be safe and effective in 3 different phase 3 clinical trials, but it's currently back into safety trials just because they had to reformulate part of the patch and they just have to show that it's still effective and it's still safe for kids. So they're starting that later this summer. So not currently FDA approved, but hopefully compared to something where you have to eat and you potentially are going to have symptoms and reactions to things that kids don't want to have and parents don't want to see, epicutaneous or the patch has very, very few side effects except for like skin rash. And so sometimes that's something that parents want to consider instead.
Are they eating the peanut whole or as a powder?
Oh, for the oral immunotherapy? For oral immunotherapy, OIT, they're eating powder mixed into something like yogurt or applesauce or whatever else they're tolerating. Once they get to maintenance, I will usually talk to parents about switching over to a real world food equivalent. For example, Reese Pieces. 4 Reese Pieces is equal to a 300 milligram maintenance dose. So sometimes kids do better with their candy medicine that they take every day instead of continuing to do the powder. But that's a great question. And then thinking about Xolair. So like I said, this is the newest FDA approved medication. We just got word of it a month ago, but essentially it's a monoclonal antibody. It blocks IgE, which is one of the key drivers in the food allergy response. It's an injection medicine. So that again comes with its issues, especially when you have much younger kids who really hate to get shots in the first place. But you have dose and frequency that are going to be determined by someone's weight and their total IgE level. So for food allergy, it ranges between 75 and 600 milligrams, and the frequency is every 2 to 4 weeks. It's been used for a long time, and it's already used for asthma, chronic hives, nasal polyps, and now food allergy. So FDA approves first medication, super exciting because it's available for multiple food allergies, whereas your OIT and your SLIT, for the most part, are going to be one food at a time. This helps to cover multiple food allergies at one time. And this was based on the data from the Outmatch trial, or omalizumab, for the treatment of multiple food allergies. And again, for the first time, this was looked down to 1 year of age. So the people on this trial were 1 and up. The majority were between 1 and 11 with a median age of like 6.5 years old. They had multiple food allergies. So in order to even get into the study, you had to have a peanut allergy, and then you had to have 2 other food allergies, including it could be milk, egg, wheat, hazelnut, walnut, or cashew. And what they showed is they looked at Xolair versus placebo, so receiving just a blank injection, which is kind of sad that they had to go through that. So we thank the people that were in this trial. They were given it for 16 weeks or 4 months, and then they underwent challenge again, and they showed a significant decrease and significant increase in their reaction threshold, meaning they were able to tolerate more and more of that protein after being on the Xolair for multiple food allergies, which is really exciting. But again, everything comes with its caveat, because there were still people that were non-responders. So about 14% of people did not see that benefit, which makes it so that we have to think about it in different people and think about how we're going to figure out what works for one family versus what works for another family. So just to summarize, because I talked about a lot of different therapies and said a lot of words, we have FDA approved therapies, which is Palforzia, the peanut OIT product that's ages 4 to 17 years old. It was approved in 2020, right before the pandemic hit. There's Xolair, or omalizumab, for multiple food allergies ages 1 year and up. That's an injection medicine, and was approved in 2024. We have off-label therapies, which are still effective and still safe, and we know that from the data we've seen. But that's OIT. It's available in many clinics across the US and globally. It's available for many different food allergens, and the age really depends on the clinic that you're in. SLIT, again, is safe and effective for peanut in research studies, and it's available in some practices for many different food allergens, and has less adverse symptoms than OIT. So it might be something and you don't have to worry about the exercise, or if they're sick, you avoiding the dose, or all of these things around scheduling. So sometimes that's an option that people want. And then still under study is that peanut patch. What do we offer at the Burghardt Food Allergy Center for now? So we just started our oral immunotherapy, or OIT program, February 1st. And so we're providing OIT for pediatric patients who are 1 to 18 years old with peanut, milk, and egg allergy. We're also expecting to add additional foods by next year, including tree nuts and sesame. Again, you're referred to the program by our allergist after your initial evaluation. Most of the time they'll go have a virtual consult with me, discuss the risk and benefits of OIT, and then they undergo either the entry challenge or their escalation day, and then we do the updosing visits as well. We're hoping to start SLIT for peanut in the upcoming year, but it's not currently available. And then Xolair is now approved, and we're offering that for food allergy in our clinic. I think a big takeaway of this talk for food allergy treatments is food allergy treatment is not a one-size-fit-all. So you really have to think about what's important for your family, what's good for your child, and then talk with your allergist to make a shared decision about how you want to move in therapy. And the food allergy treatment may change over time, right? So it might make sense for your 1-year-old, your 2-year-old child to be on OIT, but then as they get to school age and they have activities, maybe it doesn't make sense to do this every night. Maybe SLIT makes more sense because then you're not having to worry about those adverse effects or the scheduling. Maybe when they go off to college, it makes more sense for them to do Xolair, an injection medicine where they're not having to worry about remembering OIT or SLIT every single day. So I think there's a lot of opportunities with food allergy treatment and trying to improve people's quality of life and reduce the number of reactions they have. But I think we also still have a long way to go because, again, we don't have a cure for food allergy. We're essentially helping people live their lives a little bit better. But if we could just prevent it or cure it, that would be amazing. And that's it. So questions?
What I'll do is, whoever's not eating or any of our speakers mind coming up, and then we'll open it up to the whole group.
Perfect. That sounds great.
So yeah. No. But feel free to ask anyone in the room. But thank you all. Okay, and then I was going to pull up questions too from our online audience before and submitted questions. But you guys go ahead and start while I look for those.
Go ahead.
I have a question about OIT and SLIT. So my daughter is 10 years old and she had peanut and tree nut allergy, and they have more. But she started OIT when she was before when she goes to kindergarten, and she continued. She maintained eating maybe 2 peanut M&M every day. And one time she had really bad hives at school, so we stopped it because it could be from the peanuts. So we stopped it, and but we a couple months later we found out it was not peanuts, it was apples. So she developed another allergy, but she stopped the therapy. So I was thinking to go back to allergist and start the therapy, but also she does not like the taste.
Yeah.
So does it have a peanut taste, or does this create oil?
Yes, I will summarize the question. So she was saying that her daughter was previously on OIT for peanut, but unfortunately had an episode of hives at school. And so thought was secondary to the peanut, stopped OIT, and now is thinking that they would like to go back on something. But as with most kiddos this age, it gets harder to do OIT because the taste to them is awful. I mean, their body knows it's something they're allergic to. And we see this a lot in our research studies too, where it's very hard to get these kids to want to eat it because of the taste. As far as in the studies that were done for, and so is SLIT taste better or does it have a peanut taste in general? At least in the SLIT studies where they use skin testing extract, the kids actually did well and did not have the same experience with taste as they did with OIT. And so it was a better experience for them overall, and they felt like they could do it, and they were very compliant. I think the compliance rate in most studies was like 95% compared with OIT where people drop off. Yeah, of course.
I'm sorry. You had your hand raised earlier. You had mentioned that Xolair was maybe better for like college students or something because they wouldn't have to deal with it every day. How often is that treatment? How long does it last?
Yeah, no, that's a great question. Thinking about how long does the treatment for Xolair last? And I think one to mention about all the therapies, right? It's for desensitization or that bite-proof protection. So certainly none of them are going to allow you to freely eat the food. And then just like with OIT or slit or even the patch, once you stop it, you start to lose your protection. How long that protection lasts, we do not know. We're still following these kids up in the outmatch study, so they're still in the stage 3 part of that. So we don't know how long. I think it probably 3 to 6 months, you're probably protected if you were to stop it, just knowing kind of how Xolair comes off, but you're ultimately gonna need it as a lifelong or long-term therapy. But I would say for a kid who's in college, for example, maybe they only need it during college. So maybe they get their shot every 2 weeks to a month for the 4 years they're in college. And then after they get out, they're a little, they're not worried about, they're taking less risk-taking behaviors. Like I'm not going out and drinking alcohol with my friends and partying all night or maybe doing drugs or something else like that. I'm at a steady job and I know how to avoid my allergen. I'm feeling safer about things and maybe they stop it at that point. But we're still figuring it out because it just got approved.
2 weeks to a month, they would need
Injection, yeah, and depending on their dose, right? Assuming it's a bigger kid with maybe a higher IgE level, they could need 600 milligrams, what could be up to 4 shots, like 2 to 4 shots. So you have to talk with the kid and figure out what they're going to be willing to do and what makes sense for them because everything's about consistency with these therapies. If they're not going to do it, then it's not going to help them. Essentially.
Yeah.
Yes.
Injections be always in an office, do you think, or do you think it would be like at home?
Yeah, so like Xolair for other conditions, so just asking like when you do Xolair, you always have to come to the office for an injection? And for the first 3 injections, we have people come. For the first one, we have a prolonged observation period of 2.5 hours, and that's because there's a very low risk of anaphylaxis. And so we want to make sure that patients are safe. After that 3rd dose where you've been observed, if family is okay giving it, they get teaching on how to give it and they can give it at home. Which is also nice for families when you think about the fact that some people live hours away from our clinic. And so maybe it doesn't having like something that you have to come every 2 weeks for updosing or things like that may not make the best sense for them.
For food allergies, or does it also work for?
It works for lots of other atopic conditions. So it's used for asthma, it's used for chronic hives, it's used for chronic rhinosinusitis with nasal polyps. So a lot, for kids that have both, right, asthma and food allergy, which is a decent amount of the time, sometimes I'm like, maybe this is the medicine for you because you've got poorly controlled asthma, which then puts you at higher risk for more severe reactions with your food allergy. And so I'm killing 2 birds with 1 stone.
Unfortunately, I don't know why.
You would think like for eczema.
Yeah, for eczema, the results are disappointing. So I really haven't seen much improvement in eczema. I think it is a case by case basis. There are some patients who see improvement, but it's not currently a treatment for atopic dermatitis.
And what's really interesting is what works really well for atopic dermatitis, Dupixent, didn't show to be useful for food allergy. They looked at that too. And so there's enough similarities that they come together a lot of the time, but there's enough differences that you can't always use the same medication across everything.
This might be just a question I go look on the internet for. But what is the difference in the mechanism of action between the Dupixent and the Xolair? Because you said the Xolair was blocking IgE. Yeah. How does Dupixent work?
Yeah, so they're both what we call monoclonal antibodies, which are these synthetically produced antibodies that target a very specific part of the immune system. Unlike prednisone just knocks down the entire immune system. This is very specific. So like I said, Xolair blocks IgE, and by reducing IgE in the body, we're making mast cells, which are the cells that release histamine, less functional. Dupixent, on the other hand, blocks a receptor called the IL-4 receptor alpha. And that is an important receptor found on various immune cells that promotes the type of inflammation you see in eczema and asthma and food allergies and things like that. And it's a little bit more higher up in the inflammatory pathway. So it blocks more of the immune cells that are important for this kind of inflammation. And And Dupixent, again, works really well for eczema, for asthma, for people with really bad sinus disease. And so there's a lot of, it's a super important molecule, but for some reason, for food allergy, didn't really do as much as we thought.
So honestly, one quick comment on that, in that now we have longer term data on dupilumab is what the generic is called. And with time, like after 16 weeks, you get about a 50% reduction in all your IgE, including all the specific IgEs. That's not enough to make a clinical difference, but there's some reports now coming out, like after 2 years of use, the IgE starting to drop. You're reducing that whole system, and there's some soft data to show that maybe some of these clinical symptoms of allergy and food allergy could be adjusted by using this approach. It's just long, it's not the direct IgE blockades. You're not going to get a quick response, but hopefully, like with many years or potentially of use of dupilumab, we could see some improvement in these allergies as well.
I think that's one question I get from patients is in pediatric population, like going on dupilumab, will that decrease my risk for food allergy, asthma, things in the future? And we do not know that certain at this point, but maybe. Yeah, that's exciting, right? Yeah.
Not been tried, sorry. The study has been planned.
Yeah.
Can you treat eczema early? One of them was with dupilumab and prevent all this. It's a really hard study, as you'd imagine. Giving shots to little kids who are at risk. It'd be nicer to kind of have a better prediction test to see who is going to give even if someone with mild eczema, a parent, if you knew they had a 100% chance or 90% chance they're going to get asthma, then maybe you would be okay with a shot treating your eczema, mild eczema, but we're not there yet.
And they're also now, there's a clinical trial that's ongoing or they're recruiting for where they're going to look at dupilumab with omalizumab or Dupixent with Xolair for food allergy to see what happens with that. But I think it will also give us some nice safety data because we do have kids that are on Dupixent for their eczema, but we're talking about Xolair for their food allergy and how those interplay. And so far, it seems like all things are going to be safe, but I think it'll be nice to have solid clinical data that shows us that too.
So I don't really have a question, but I have a little story that might lead to a question. So I went to a dermatologist. My regular dermatologist didn't know what to do with what was at the time like all over body rash. And so she referred me to a different dermatologist, and they did all kinds of testing, and I ended up getting prescribed Dupixent. And Dupixent was phenomenal. Like, it took all my eczema away, but I developed a horrible facial rash, like horrible. Like, you wouldn't want to go outside your house with it. And the dermatologist didn't want to see me anymore when I said I had done research and there was like a 4% of people who get this facial rash. But the miraculous thing that happened is that, so I have an autoimmune form of colitis that I've had since 2006 with horrible symptoms. After taking the Dupixent, even after I went off of it, all my symptoms of my colitis have gone away. And I mean, I'm not a doctor. I haven't seen my gastroenterologist yet, but I just wondered hypothetically if it has to do with the more like systemic anti-inflammatory properties that Dupixent gave me. So
I'll let you guys comment on can you get eczema in the gut and allergy in the gut?
Yeah. So Dupixent, dupilumab, also has an indication for eosinophilic esophagitis. And that is it's the esophagus, which connects your stomach to your mouth. And it has been shown to be helpful in that condition. Colitis is a general term, just like eczema is a general term. There's a lot of different ways you can get inflammation of the colon. And so in theory, there are some types of colitis that can be driven by a very similar immune mechanism as eczema or eosinophilic esophagitis or whatnot. So if you take everybody with colitis and you put them on Dupixent, it's not going to make a difference for most people. But there probably could be situations where we get lucky and it does make a big difference. And so, potentially. First part of the question too about.
I might let Dr. Simpson comment on the facial rash.
No, you're absolutely right. So it's a rare side effect of Dupixent, and it's in the package insert, was added to that because of this experience. I train dermatologists that not all facial, like if you're on dupilumab and I show pictures of patients who had facial rashes, but it was like from contact allergy to they were on Dupixent, but contact allergy to their nail polish, or a rebound from someone had given her prednisone. So so I always say, like, still kind of think through what are the possibilities of facial redness, but one of them is absolutely Dupixent. Yeah.
Has Xolair been on the market for use?
Oh, for in general? Yeah, so chronic, it gets a first approval for asthma back in 2003. And so it's been on the market since 2003. That was only in adults initially. Over time, now it's approved for kids with asthma 6 and older. It's approved for patients with long-term hives for 12 and older, and for nasal polyps, so that's inflammation in the sinuses, for 18 and older. And then now it has the food allergy indication for 1 and older.
And are there side effects to Xolair that have been found? Negative reactions? Because you said you keep them at the clinic to watch because people can be allergic to it.
The main one that I warn people about is that allergic reaction. So the question is are there side effects to Xolair for those people at home? So the main one that I warn people about are those allergic reactions, but we don't typically see the reason why we give it in the clinic for the first 3 times, and that extended observation is it typically happens in those first 1 visit or 3 visits. And honestly, I've never seen an true allergic reaction to omalizumab. It is approved for random hives and swelling too, so it's sometimes difficult to bear out the data, but that's the main one I warn people about. Do you guys warn people about anything else when you talk to patients about Xolair?
With most injections, you can obviously have like local reaction, like itchy, swelling. I've had some people with a little bit of hives just around the site, but nowhere else. Another one I got from a few of my adult patients with chronic hives back where I trained was some very like joint pain or like nausea, headache, like very general kind of symptoms, but nothing that made them stop the medicine because the medicine was so helpful.
No.
Some of the inhalers, right? They have long-term, they've noticed slight long-term differences, but not Xolair.
No, not with Xolair. So for the 20 plus years it's been on the market, plus the 10 years leading up to that to get approval in the first place. So patients have been on it for 25 plus years at this point, and we haven't seen anything. But I think in general, with any of these medications we talk about, in medicine, everything is a risk-benefit discussion, right? There's always going to be potential risks for anything that we do. And that's not even pharmaceuticals, right? Just avoidance of a food. There's a risk to that. There's a benefit to it, there's also a risk. And so these are the conversations that you need to have with your providers to be, is this option, what are the risks, what are the benefits? For this option, what are the risks, what are the benefits? And really go through that because it's very personalized. And since Xolair's been approved a month ago, I've had this conversation with so many parents. And I would say each one of them comes up with a different solution. Some of them are saying they're going to go Xolair, some go with OIT or oral immunotherapy, some want to keep avoiding. It's really individualized. And so just spending that time with your provider, being like, I want to know what all the risks and benefits are for this one therapy, but also for these other ones. Because so you can make an educated decision with your provider. Because I think the worst thing for a provider to do is tell somebody, you should be on this therapy, because it may not be right for the family. And if they don't know all the important factors of what's going on in that decision, it's not going to work well.
So my question is, we have seen that like with eczema, there is a chance of false positive for allergies. Like for my kiddo, he has the IgE values for ounce, but he's taking it, he's doing fine. So I haven't given him sesame and soli till date, 15 months, but he has IgE values for that. So do you recommend that I start it now and see?
So asking about IgE testing, and now that we have positives for things that he had not previously introduced, correct? Now that he's had positives, I would just recommend probably doing a challenge with your allergist in clinic first, and then going home, if he tolerates, then going home and eating. But I think you speak to a very important point just about testing in general, that if we haven't had it yet, then it becomes very difficult to interpret these IgE results and figure out what to tell parents. And you were speaking about the differing levels too. So like for peanut, I think you said it was 0.97, and then for almond, it was like slightly over 2. And what's the difference? Really, when I'm looking at those levels of testing, because people will always ask, well, does this mean I'm going to have a severe reaction or a non-severe reaction? Testing cannot tell us the severity of a reaction. It tells me the probability that your kid might react. So the higher the level of IgE, or the bigger that skin test is, the more likely you're going to have a reaction. But that may not be always the case, right? Because your peanut IgE was lower for him. He had hives immediately, whereas almond tolerating that, and that was a higher level. So I think it's definitely reasonable talking to your allergist to see if we can get these foods in his diet, because a lot of times they could be false positive, and it's not a benign treatment to avoid a food. So the more you eliminate, or the more you have kids avoiding foods, you're affecting their nutrition, you're affecting parents' view of how to feed their kids. And so we have to be really careful when we're thinking about that.
I did start giving him almonds from 6 months. Was there any reason that he developed tolerance for it?
So potentially, right? So the earlier we talk about earlier introduction, helping to promote tolerance, because the longer you avoid a food, the more likely you are to become sensitized through other areas of the body that's not the gut. And then you are more likely to develop an allergy. So you introducing it early was a great thing. I encourage parents to introduce early if they can. It's just sometimes I think in this day and age, we are medicalizing feeding a lot because people are so worried about the food allergy realm. And so then it becomes this anxious thing that parents are doing instead of this fun thing of just feeding your kid and having a good time with it. But you certainly probably maybe prevented him from having that allergy. It's hard to know, right?
So we have been raised to give, so whenever we have some of these mild, and sometimes all these foods they just trigger eczema. So because it has any other things they trigger eczema and all these substances. So not these allergies, but generally. So sometimes we are at least it just gives increase having trouble scratching loss, we might not be able to sleep. So we are doing it once in a while. My question is, we have been also told by the allergists that they might eventually outgrow it, like 5 or something. So by giving these kind of Zyrtex regularly, will it reduce the chances of overcoming this or getting the tolerance?
Giving like an antihistamine like Zyrtec over time reduce the risk of, or like help you outgrow it. Is that what you were saying?
Will it outgrow or will it stop making outgrow it?
No, giving antihistamines is not going to impact whether they outgrow or don't outgrow. But you're right, there are people who do outgrow their food allergies. A majority are going to outgrow the egg and the milk, but there's still 1 in 5, 1 in 4 people that outgrow their peanut allergy, which is important to keep bringing up with your allergist, keep getting that testing, because usually it's going to happen for peanut tree nuts, it's going to happen majority by 8 years of age. So we really, if I can get a kid back on peanut or I can get a kid having tree nuts again, I really, really try. And so that's where we're doing that testing every single year.
Okay, I have a couple questions from the registration. So, okay, so we'll do a rapid fire potpourri here as our last. Okay, so let's see. Okay, so one of the questions, will it ever go away? I think we've addressed that quite a bit. Is almond milk bad for the skin?
Like almond.
It says almond milk.
Almond milk applied to the
I don't know
skin.
if it's, I can't tell if it's applied to the skin or by mouth.
I guess I have not heard of that as a something you apply topically. I don't think that it would be very good as a barrier, the way that we talked about, moisturizing being important to help with the skin barrier. So that would be my answer. I don't think it would be.
Yeah, maybe interesting.
I was going to say, just to piggyback off of the skin barrier and things, when people have a lot of time will ask, well, should I just rub it on their skin first? Like, should I rub peanut butter on their skin, or should I rub that? And versus just eating it first, because what if they have a reaction? And I always say, avoid rubbing the food on the skin, because in a kid who has eczema, you do have that impaired barrier. There's a chance you get sensitized through that method, and then they do have a more severe allergic reaction. So I always say through the mouth is better. And I wouldn't rub on the skin just for introduction purposes, just to add to that.
And almond milk, do we know if this is a pediatric or adult? Okay, so almond milk in young kiddos isn't the best nutritional milk. And so a lot of people go to it because it's really easily accessible and things like that. But we generally soy milk is better. There's a lot of hydrolyzed formulas that are better, like cow's milk based, that are safe in kids that have milk allergy. And so in general, we don't love almond milk as a replacement for cow's milk or breast milk or anything in younger kiddos. And then in general, one question we always get, and being Indian, almond oil is often given as kind of topical therapy for young kids. And so a lot of families use almond or coconut oil or things like that. And in general, they're not as good of a barrier to help kind of with the eczema in the first place. The second is, theoretically, if it has protein in there, just like what Dr. McDougall was saying, we may be sensitizing the kid. And so in general, we try to avoid vegetable or nut oils in young kiddos, especially with eczema.
Which is, and we didn't talk too much about, but we alluded to it today. There are many mouse models, for example, where you put peanut protein on the skin, and the mouse wasn't allergic before. You put peanut protein only on the skin, and then they get allergic to it. They get really high IgE. Dr. Haniff would always say the skin is a high IgE producing organ potentially, which is why I'm so confused by the skin patch test on peanut immunotherapy. They didn't see increased peanut allergy; they showed it decreased.
Well, all the kids were
already had peanut. Yeah. All right, so I guess at that point it doesn't matter. Let's see. Oh, so I don't want to give out like direct health care advice, but maybe you can talk in generalities. I suspect I'm reacting to chicken eggs, and this is most evident when eggs are the main ingredient, not necessarily, would duck eggs also be a problem? Any comment on cross-reactivity, I guess?
We don't know the exact rates of cross-reactivity between duck egg and chicken egg, but there is cross-reactivity there. And so if there's concern, and it depends on I don't know what symptoms this individual is having, but it really depends. And they're saying the level to which the egg is in there. So can be baked egg versus not baked egg. There's lots of different things. But if the symptoms are hives, swelling, vomiting, things, I would probably talk with your allergist prior to introducing. If things are just gut upset, like maybe some belly pain or diarrhea or things like that, I think more on the food intolerance. And so it might be how it is prepared, or maybe the amount that you're getting versus actually having a food allergy to it. And so I think it would be important to delineate that. But there is certainly, for a food allergy perspective, cross-reactivity between those.
Great, thank you. And then Julie might be able to answer this one. So it's a question of these kiddos with allergies, asthma, eczema. What are the best practices for like long-term success as they grow? Should we be making sure the kids have the skills for their own medical management, and how can we coordinate care better?
Yes, I think long-term care, in my presentation talked about that routine of having a skin routine and really getting in the habit of putting on a moisturizer, trying to avoid soap as much as possible, the bathing practices. I think starting that early on and really teaching that to the child can take them a long way. Early on, of course, the parents are going to be applying any like topical medications, helping them with medication management. But I like to see, the kids sort of take that on as they get closer to puberty. Taking some ownership, asking questions about their skin. I start asking them, more about how things are going at school and how things are affecting them. So really, acknowledging like this is, your skin and how can we make you feel better? What are the things that you and sometimes or often there's some negotiating that goes on later on, right? Because like teenagers, they're like, I don't want to apply my moisturizer. I don't want to do these things. So there's some negotiating that goes on, like, oh, well, ointment versus cream and things like that. So yeah, I think that answers that question.
Yeah, great. Thank you. Other questions or any questions online?
Online, the first is.
Get a seat.
Okay. We eliminated gluten and dairy from my child's diet in an effort to prevent eczema flares. Now that I have learned food elimination is not currently evidence-based, how should we proceed? He's currently on a gluten challenge for upcoming celiac blood testing. Would you recommend reintroducing dairy as well? He has gotten highs after dairy, but it was hours later. Not sure if that constitutes an immediate reaction or even if it was a causation or correlative situation.
Yeah, and then you guys can feel free to jump in because that's a hard case. It sounds like they've already introduced. So this is a question about gluten, and they've already reintroduced gluten for an upcoming celiac challenge because you have to be eating gluten to do that. Have a great test result or an accurate test result, and then could they reintroduce cow's milk? And it sounds like they had one probable not reaction with very, very delayed hives. I would say in general, if it's like quite delayed, like greater than 4 hours later, it's almost certainly not a real food allergy. And so I would probably attempt reintroduction at home, given that they didn't have any other symptoms. But if it was closer, I'd probably talk with their pediatrician. And you can certainly do it, in a graded fashion too, where you give a little bit and then a little bit more after 15 minutes, as long as they're tolerating it. But what would you guys say? I don't know. That's a hard question.
Yeah, I would say the same.
Yeah. As long as it's delayed hives.
Thank you.
Yeah.
And then this is another more patient experience comment. They say, I ate egg since I was 3 months old, but was diagnosed with an egg allergy when I was 3. Didn't stop eating egg. Wasn't told by my mother I was allergic. I was then diagnosed with an egg allergy again at about 27. The allergy has grown since then with avoidance of the allergy. Early introduction does not always work.
And Dr. Joshi says, agreed. So did you have Carmen, you had a microphone during it? I don't know. I think that's just echoes that every patient experience is different. And right, we're talking about more generalities and the most common presentations and most common treatments and stuff like that, but every patient experience is different and unique, and that just echoes that sentiment.
Yeah, I was going to say something similar towards the end, that like this, we don't know it all. And so if patients tell me that this food seems to make their eczema worse, as long as they're not on an extremely restricted diet, there's no reason for me to not validate your personal experience. So everyone has their own lived experiences. So we're not saying that that's not reality, and we don't know everything. I was going to say one thing about this early testing. So in the LEAP study, even in if you had a small reaction to peanut, and it didn't qualify at there's a certain level of how big it is, but even the participants who they might have been told they had a positive, like let's say in this situation, and they had a small skin prick test positive at 3 millimeters. It didn't count as an official positive, but they have reactions to the food by testing. They were actually included in the study, and they were fed peanuts, even though they had a allergy to it, or at least a positive test, or a borderline positive test. And then they looked at eczema, and you look at the eczema severity between the two groups, and actually it didn't matter to the severity of their eczema that they were being fed this like potentially borderline positive food. So a lot of unknowns, but. Okay.
One over here.
So, somebody asked about almond oil on the skin, and I'm wondering about other oils with regard to rebuilding the skin barrier, fattening up that tissue, since a lot of the treatment for eczema and then the top layer of skin is there anything supporting emu oil, jojoba oil, or castor oil to help rebuild that skin layer?
Yeah, we don't, I wouldn't say we have extensive studies on different kinds of oils. Most of those are kind of on coconut oil, sunflower seed oil, I think mineral oil are all sort of tested like, they can improve the skin barrier. They may not be quite as quote unquote, like moisturizing as a thicker ointment. The thought behind moisturizers is kind of misleading. They don't actually like get into the skin. It's more often that they sort of sit on the skin as a layer and prevent further moisture from like getting out. And so, in general, when people are asking about oils, I say, we have some like soft studies for coconut oil, sunflower seed oil, mineral oil, like if you want to go that route, but they're not going to be quite as good as a barrier as like Vaseline or Aquaphor. I think we have some, again, like negative studies for like olive oil, castor oil being a little bit maybe like not damaging, but like they're not as good for the skin as some of the other oils. So
there was one study that showed mustard oil was harmful to the skin barrier,
Yes.
and
Yeah.
even olive oil. And
yeah,
my colleagues like in India are like, we put mustard oil in every single kid. That is hogwash, And
Yeah.
so sometimes when you read studies, there's a difference between like these really careful studies done that maybe show a teeny little difference. But then there's like kind of reality.
Again, lived experience. Like, yes, I definitely, I get patients that are like, well, we use coconut oil and it's great. And so, but yeah, I don't have like the evidence or the studies to say like this will be good for everyone.
Sean, would you mind introducing Blue Spruce?
All right. So we have two lovely ladies from Camp Blue Spruce. Camp Blue Spruce is a overnight camp for kids with food allergies, which is pretty amazing. It's the only one in the country. And they do it each summer. It's 2 weeks. Is it late July, early August, or usually August are the 2 weeks? And it takes place in Southern Oregon. So we have the director of the camp, Melissa, back here, and then we have the overnight camp director that will be on site, Sarah, correct? Okay. So it's a wonderful opportunity for kids. I think we have a slide with the QR code, maybe with the info in case people want it. Do you want to introduce it a little bit, or just say what age range and things like that for the camp? I can bring you the microphone. Sorry to put you on the spot.
It's okay. I might pass it to you. Hi, I'm Melissa. So this will be our 12th season. And we do kids from age 9 to 17. So there's a teen group, and then there's the younger campers. We also have counselor in training programs. And then a lot of our longtime campers become counselors. So we kind of have that full circle going on. We are the only camp in the country that solely focuses on kids with severe food allergies, celiac, and other atopic diseases. And the great thing about the camp is, there are not any of the top 9 allergens on premise on the site. And then, of course, with these kids, they come with a lot of other extra allergens. So our kitchen probably deals with 30 to 40 extra allergens every summer that we try to accommodate. So, but it's just a summer camp. Like, they go hiking and, do arts and crafts and all the stuff you do, at summer camp. It's just the only difference being it's a safe environment for them. So, yeah.
Great. What a great idea. Thank you for helping our kids with allergies. So, well, any last questions before we wrap up? Okay, well, I just wanted to acknowledge our presenters. Thank you so much for dedicating your lives to helping patients with these conditions and putting on great talks and sharing all this amazing new information. Thank you to sponsors of these moisturizers and emollients over there. Thank you to Camp Blue Spruce and to Pollo Norte for the food. But most of all, thank you guys for being involved and like engaged. And it's going to make this beginning of this eczema center way better. It's going to really help out the food allergy center. And so we look forward to more partnerships and more events. So thank you so much. Oh, I messed up. Carmen wants to say something.
Okay, I just wanted to share with you guys real fast. We have a feedback survey as well. So you guys can share questions for next year or so forth. Thank you all again.